Welcome, welcome, welcome. Please be seated. Make yourself comfortable. We're going to have a fantastic day. And my name is John Taylor. I do the morning show on KGay 103.1 radio here in Palm Springs. And hey, we got to start off. It's a beautiful day in the neighborhood. A beautiful day for self-advocacy in healthcare. 2. Yes, this is our second self-advocacy in healthcare conference. Give yourselves a round of applause for being here. This is where confusion gets a game plan. And I know I've had a plan that's called confusion for most of my life. But we're going to help you demystify this labyrinth of healthcare that we have in these United States. You're going to hear from expert patient advocates, insurance and legal pros, even end-of-life education specialists, because this is a limited time offer. We want to make sure we have the best possible dismount. Yeah. Whether we go up or down at the end of the rainbow bridge is not for us to decide. Now, we're also going to have a candid panel of healthcare providers so they can give you the provider eye view on how you can become partners with your healthcare provider. These are practical tools, and this is the way you can learn how to advocate for yourself and others. And we do that in this lifetime. We take care of others. So we want to make your medical visits productive. You know, I have a doctor's appointment, 10 o'clock Monday morning. I am totally taking notes. We need to give you the tools so that you can learn about how to get the most out of your health insurance, your end-of-life wishes, and end-of-life care. This initiative is brought to you by the HIV Positive Aging Research Project. Yes, give them a round of applause. I'm taking that lozenge out of my mouth. I probably didn't need to announce that. I could have gotten away with it. We want to thank our sponsors, our community partners. And because, you know, this is the gayborhood, this is a village. My job is village idiot. These are the community partners that really make a difference in the lives of our gaybers here. The LGBTQ Community Center of the Coachella Valley. Yes, centertv.org. Keep the applause going for Jewish Family Services. Yay! Brothers of the Desert, who brought their own little black buddy. Love the Cottontail. Eisenhower Health is here. Stonewall Gardens. Triangle Care Management. Scan. Gilead. Desert Oasis Healthcare. DAP Health. Our friends from the Transgender Health and Wellness Center. Bellamorte Doulas Services. Thank you, thank you, thank you. And please, if you haven't done it already, make sure you visit each of their tables and you will get a complimentary ballpoint pen. Yes, you will. There's going to be a full inked up pen cup when I get home. All right, just a little bit of housekeeping. We are here. Oh, we have to do a moment where we want to be silent because we want to recognize that we are gathering on the traditional and ancestral lands of the Agua Caliente Band of Cahuilla Indians, a federally recognized tribe based in Palm Springs. We honor and respect them as the original stewards of this land, and we acknowledge the elders, indigenous people today, and the future generations. So we want to make that. All right, we have exits. There's one right there. Wave over at the exit. Our lovely flight attendants are here. We have an exit over on the other side that leads to the outdoors. We have bathrooms that are located in the hallway. Please, use them. Pop up a puddle. But it can happen, right? That one time, all right? Photography. If you are sitting from the third row back, you won't end up in the photography that we have. We are going to be doing a replay of this so that people all over the Coachella Valley who couldn't make it today were able to see the program. So if you don't wish to be photographed or recorded, the first few rows You want to be behind them. Does that work? Yes, it does. Now, in addition to today's program, we are asking you to fill out a survey. You saw the survey on your seat. Now, when you fill out your survey, when you turn it in, if you put down your phone number or your email address, will be entered to win a fabulous $125 certificate to Patrick Smith Skincare, a premier esthetician here in Palm Springs. I haven't been. This is a before picture. You can win it by turning in the survey at the registration desk at the end of the day. We appreciate that because your feedback really does shape how we make this program happen. So, it's important. You will notice handsome volunteers. They're from Gay for Good. Thank you, Gay for Good. They are going to be here when there are portions of the program where your questions are valued, but we want to make sure that you are heard in the room and also heard on the recording. So please wait with the question until one of our handsome microphone bearing volunteers comes to you. We want to capture that for the audio recording. So, to start off today's conference, we are focusing on advocacy and your healthcare toolkit. And Brittany Cabañas is very well known as the executive director of Stonewall Gardens on the board of Triangle Care Management. Brittany is a licensed nursing home administrator, an LNHA. And she's also an RCFE administrator. And she'll tell you what that means because they didn't write that down here. I'm dying to know what an RCFE is. She has dedicated her life in her career that began at age 17 to be a caregiver and advance into leadership in the healthcare community, a specialist in senior care. She holds a Bachelor of Science in Public Health and is pursuing her master's degree, is active in Coachella Valley nonprofits supporting seniors and their families. She's a dedicated parent and spouse, and she remains committed to serving her community with compassion and integrity. Please welcome Brittany Cabañas.
Okay.
Oh, you're coming in too?
Yeah.
Oh, I thought Brittany was the solo. Okay, I'll put that right over. And we would also like to welcome Stephen Drew Auerbach. He is the co-CEO, the executive director, co-executive director, and COO. He's a cuckoo. Okay. Stephen joined HARP 5 years ago, and after a 30-year career in informational branding and product development, he served on nonprofits including the Design Industry Foundation, Fighting AIDS, and most recently Triangle Care Management. He's also consulted the Venice Family Clinic and worked in in-home health care services for the state of California. He has had a career that has advocated for individuals, helping them partner with providers and navigate systemic barriers in healthcare. He's helped me a lot personally. The co-executive director, COO, HIV Positive Aging Research Project, Stephen Drew Auerbach.
Okay, welcome. It's our second conference, as John told us. I wanted to just start by saying that you all have a notebook that you got when you walked in, and hold on to that. There are a lot of forms in there. Some of those forms you're going to want to make copies of, but we've given you a couple of sets. But I want to start this year just like I did last year, so forgive me if you've heard this joke. My father was a healthcare advocate for 50 years, from the time he was 21 until he passed away. And he had a favorite joke, and his joke was, guy dies and he goes up to heaven, and he's standing in line at the pearly gates, and he's just hanging out waiting his turn, and while he's waiting there, he sees this other guy going up and down the line with one of those like doctor things on their head, and he's checking everybody's heart and their ears and their nose and stuff. And so he says to the guy next to him, he's like, who is that guy? He goes, oh, that's God. He thinks he's a doctor. My dad was a card. So I want to start this just by saying that, your doctor is, where is our clicker? Your doctor is your partner. It's probably the greatest and most important partnership you'll have in your life, other than the person who maybe sleeps next to you. Your doctor, and our view about doctors, needs to sort of understand that. All of us, I don't know if you've been in the situation where you go to the doctor, and first of all, you might be a little nervous to begin with, right? You might be getting test results, you might be, whatever it is, and you're there, and they just talk a mile a minute. And then you leave, like, was I supposed to refill that prescription? Was I supposed to follow up on that test? Did I ask him about, what's this weird fungus growing on my foot? Whatever it is, So the first thing is that, the thing with your doctors is, if you look at it as a partnership, and I think what happens all too often is we start looking at it as an adversarial relationship, because you're not getting the answers you want, you're not getting in when you want. Hopefully today we'll give you the tools to be able to meet all those goals. But you also need to speak to your doctor about things from your last visit. Who of us has been to the doctor and you've been to another doctor and they put you on a new med, and then you end up getting the doctor prescribing something to you, but he doesn't know that you were put on this new med, or you think he knows because it's in my chart. Well, for example, I have 3 different my charts. One is Eisenhower, one is DAP, and one is Loma Linda. So they don't always talk to each other unless you point it out and the doctor has to see into it. So it's a very important thing to have that level of communication with your doctor. One of the things that I want to go over, this is our agenda for today, for this segment. Why do we need a healthcare advocate? And along partnering with this, how can you be your best advocate yourself? Brittany's going to talk about that shortly. How to choose an advocate for you. Who is somebody you would trust? It doesn't necessarily mean, do you want your family member to be your advocate? I don't. But you need to have partners. How to be successful. That is your self-advocating toolkit, which is in your folder. How to be a successful advocate, and then how to make your way through the healthcare journey, from doctor visit to, what did you say, dismount. Yeah. So we're going to cover all of that today. Oh, it's a B.
That's a B.
That's a B.
Yeah. Okay, so can you guys hear me here? Okay. So why do we need healthcare? This.
That's gonna do it.
So why do we need a healthcare advocate? Healthcare advocates can empower the patient, help facilitate clear communication, assist patients in navigating the healthcare complexities like insurance or multiple physicians, foster trust between patients and the healthcare system. And effective advocacy has been shown to improve health outcomes by ensuring that patients receive timely and appropriate care. On your chair, there was a form, and it looks like this. It's labeled Choosing the Right Advocate for You. And this is a type of brainstorming worksheet that's going to help you identify that person. And I'll go through it, and you can do it as I'm talking, or you can do it later. The first part is clarifying your situation. So what issues do you need help with? Is it a second pair of ears during doctor's visits? Maybe it's someone to advocate for you during a treatment, or maybe it's an ongoing thing that you need for a chronic illness. And then what outcome are you hoping for? Are you looking for someone for emotional support or something else? And what is the urgency Is it somebody you need immediately, soon, or someone that you're gonna probably need ongoing? Second part is what do you need in a healthcare advocate? And you can add additional things here that are unique to you. These are some that I listed that are important for me when I'm looking for a healthcare advocate. And that's someone who is trustworthy, respects my wishes, is a good communicator, knowledgeable about the issue or has the ability to become knowledgeable, calm under pressure, has influence or authority, and keeps information confidential. So no gossipers for that. And when I say influence and authority, I don't mean somebody famous. I mean someone who can command presence on my behalf. Third section, who could advocate for me? So a couple people that would come to your mind that could possibly advocate on your behalf. And then why would that person be a good advocate? Is it because they check a lot of these boxes here? Is it because in the past you needed them and they were there for you? Those are all good reasons. Fourth part is a red flag check. And again, you can add additional red flags. Some red flags would be someone who speaks over me, someone who dismisses my concerns, someone who escalates unnecessarily, and someone who struggles with confidentiality. The fifth part, I put a little blurb here that you could fill in the blanks for, and I'm just gonna fill in the blanks. I'm dealing with a medical condition. I trust you because in the past you were there for me when I needed you. Would you be willing to support me by being my healthcare advocate? And then the last portion is the final decision. Also some blanks there. The person I plan to ask is Stephen. And the first step I'm going to take is completing this worksheet. That's the first step I'm gonna do. Like I said, this is a really good brainstorming worksheet just to kind of get those wheels turning to see who you think you have in your village that can help you. In your binder, I believe it's in section 2, there is a self-advocacy toolkit. And this toolkit was provided by Triangle Care Management, which is a nonprofit organization that provides care navigation for LGBTQ+ seniors. And they are here today right in the front. So make sure you say hi to them on your when you're running around here today. This toolkit provides forms that will help you track your medications, vitals, doctor's visit preparations, and medical history that can all be valuable throughout your healthcare journey. Okay.
Away we go. So these are the different forms that you have. Probably the most important one, this is the area, you have 2 sets of these forms. I encourage you to make copies of them because you're going to have to update them throughout your,
I should have brought mine. There's a book you can buy on Amazon, and it's a little book about so big. It has six columns, and then it's like 17, and I take it to my diabetes doctor, and I put the time I do it, the date, blood pressure, glucose, oxygen and all that. It's all in one little book. It would certainly beat a bunch of paper.
Yeah, so the forms are going to be in your binder, so it's going to be something similar.
But the book was inexpensive, and
yeah, you can actually get those types of books that he's referring to on Amazon, and yeah, those are great tools as well. If you don't have access to
because everything's
those
in one little book.
Yeah, exactly.
and then, also you'll see in your binder, we have the slide decks for every speaker. So if you didn't catch something the first time, you can go back and look at their actual slides. So as Alan was saying, you have to have a comprehensive medical history with you. But the most important document, in my opinion, is what are your goals for your medical visit? How many of you, when you go to the doctor, already have questions written out? Good. Okay, so about half of you. if you don't have questions written out to go to your doctor and your doctor has scheduled you for 15 minutes, you really run the risk of not having a complete visit or a really good visit. So it really starts with you. Make sure you have your goals for the visit, particular concerns, outside of normal checkup type stuff. Like I was mentioning earlier, things like what's that thing called? My chart. Things like my chart, they don't necessarily speak to each other. So if you've been to another specialist or you're following up, your doctor may not know that you got put on something else while you're doing it. So you need to just go over your medications with them and let them know any new medications, any referrals that you've been given and why. And before you walk out of the office, make your next appointment. We all know the frustration of trying to make an appointment and something's not available for 20 months or something. So the best advice I can give you is before you leave, make it another appointment. You don't even have to have a problem, just make the appointment, just so that you have it, and if you have to cancel it, cancel it. Labs, that might have been ordered, scans, anything else that you can think of, but that is your first line of defense, is being prepared. Thank you. Medical history. So same thing, always at the top, allergies. I also actually do this next to the different conditions I have. I also write down who the doctor is, because a lot of times they're not within your direct network or on my chart. So I always write down who the doctor was that did a particular surgery or whatever. The date, the hospital location, that's helpful, especially in an emergency. If a doctor has to look up records, let's say I have records sitting at UCLA in LA, they're not gonna know to do that. But if I have this, they're gonna say, oh, okay, he had the surgery at UCLA, put in my chart, blah, blah, blah. We know where to go for the records, if I can't speak for myself or have my advocate with me. Okay. Medication list. Okay, this is exactly what I was talking about. Keep your medication list and always update it. Before you go to the doctor, make sure you read it. I just went through this the other day, making an appointment, and they're like, are you still on blah, 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 and this and that, and everything, and I'm like, I've been on that for like 5 years. And what you'll also find is in my chart, a lot of times, different people enter it, if it's my chart, any kind of system, and they'll go through the drugs with you, and you ask them to take it off, or the dosage change or whatever, and the person right there does it, or appears to be doing it, and then it doesn't hit my chart, because somebody else might have gone into my chart and made an adjustment. So always go through your medications with your doctor. The other thing is, you might want to, if it's not obvious, write down what the medication is for. This is for my HIV, this is for my heart, this is for whatever. Because a lot of times medications are used off-label. So even though a medication could be for nerve pain, like gabapentin, it's also sometimes prescribed to take the edge off. It's prescribed for many purposes. So it's important to maybe just know when you go to the doctor, or have your advocate know what exactly it's for, because a doctor can misconstrue why you're on that medication. Normal logs, blood pressure log, if you're asked to do that. What's the next one? Blood sugar log, if you're asked to do that, and your vitals log. These are important because this is how a doctor will figure out and how you're trending. Again, you might have seen that you had a high blood count in this appointment, but then the next appointment you didn't, or you had high blood sugar, but then it went down. So keeping logs, especially if you're doing daily ones, is really important to honor what your doctor is asking you to do, because that's how they figure out the trends. Especially if it's like, oh, your blood pressure is always low in the morning, but it goes up considerably at night. things like that. But the only way to get that is for you personally to be keeping up with your labs. Still me? Okay. So you'll notice the S on the corner that Brittany gave me. So we're going to talk about our healthcare journey, like I said. You know, what is the healthcare journey? It's from doctor visit to end of life care. So right now we just talked about doctor's visits, and Brittany's going to move along and talk about, what's the next slide?
So this is some tips for self-advocacy during those doctor's visits. And the first part of that is to gain knowledge. Staying away from Dr. Google to self-diagnose and self-treat.
But he's free.
Right. Well, you know what else is free? Credible sources online. Like Johns Hopkins, the Mayo Clinic, websites that are .gov and .org. I mean, I could enter and I have a headache, and the next thing I know, I got stage 4 cancer. You know, you gotta make sure you're looking at credible sources. And then know the vocabulary of your disease or illness. For instance, if I had Parkinson's disease, it would be important for me to know what tremors are. Closer?
Yeah, you're good.
Because tremors are a condition, a symptom that most people with Parkinson's disease have. So I would want to know and make sure that vocabulary is something that I'm used to talking about.
So then, reiterating, the next most important thing to advocate for yourself is keeping a binder or a journal. Whether you keep it, you buy a book from Amazon, your advocate does it for you, keep your history. This is meant to go with you to the doctor. An up-to-date med list, medical history, and vital sheet. So everything that we just went over. Stand firm. So when you have, when you are there, you have your binder or whatever. So we're going to talk more later about the limitations of your doctors. And that'll be addressed in our last panel, where it's like, why is my appointment only 15 minutes? Or he's always late, or whatever, and understanding those things. So assuming that these things are outside of their control, you need to be prepared. Get to know your medical team. If you feel like I went here to a neurologist for 9 months, never once saw the neurologist. Always saw the nurse practitioner, who was wonderful, but at some point they needed a diagnosis. I had to insist on seeing the doctor. So don't be afraid to insist or wait longer. Say, you know what, I don't really want to meet with a PA, I want to meet with a doctor, if that's your preference. My personal doctor is a PA, and my previous doctor, amazing. I mean, the most amazing person. But there is a point that sometimes you really just want to see the doctor, and you should insist on that. The other thing is take notes. Get to know your doctor's team. Get to know the people who work at the front desk. Address them by name. All of these things are going to help your journey. Make sure everything is addressed while you're there. So if you're in your appointment and you know you only have 15 minutes, as long as you're the one organizing, come in with those questions, you should expect to have those questions answered. For some reason, a doctor, the timing is such that it can't happen, then write and say, okay, let's set up a phone appointment. When can I see you again? And don't feel bad about assisting. If you need a second opinion, don't apologize for a second opinion. You're perfectly entitled to one. If a doctor has a problem with that, they may not be the doctor for you. So understand that. And I don't want to again talk about adversarial relationships, but it's okay to fire your medical partner if you're not comfortable in also. So maybe they don't address your specific need, or they're not a specialist that you feel comfortable with. Never feel embarrassed for that. Never apologize for that. Just do what you need to do for yourself. Always being respectful and trying to partner with your doctor at the same time.
And then the last tip is follow-up. So don't assume that your medical team is going to do all the follow-up for you. It is super important that you do that on your own. for things like test results, prescriptions, referrals, or any orders sent. So for example, if I left my doctor's visit and he stated he was going to send me for an MRI, I would probably wait about 24 hours or so, and if I didn't hear from the MRI location, I would reach out to them, make sure they received my doctor's referral, and set up my appointment. Otherwise, things just fall through the cracks, and you'll be waiting quite some time for that MRI.
You know, to add on to what Brittany's saying is also, you know, when a doctor refers you to something, for example, if you're on IHP sends you the referral authorization, you could receive that 10 days after it's already been authorized. So always go back to the medical provider you're trying to make an appointment with and say, have you received this yet? Because you might get in faster. Healthcare journey. So we're going to move along. We just talked about doctor's visits. Were there any questions about that?
I wouldn't trust any information now from the government.
So Alan's saying that he wouldn't trust any information from the government now. Yes, and thankfully RFK is not your doctor. All right, so moving along.
Yep, so moving on through the healthcare journey, we talked a little bit about doctor's visits. The next thing that may be part of our healthcare journey is a hospital visit. And a lot of those hospital visits will result in skilled nursing or rehabilitation before we go home. So to advocate for that, you want to identify who you want by your side and who you don't. There's people we love that we don't want to visit us at the doctor's, at the hospital. So make sure that you know those people and your advocate knows those people. Identify the rehab that you want to stay at. And I always recommend that you choose a top 3 because a lot of times when it's your time to be ready for discharge from the hospital, the facility might be full and not accepting new patients. So I always recommend choose your top 3 for rehabilitation. Keep a copy, yes,
How do you
just one
find-
second, let's let me get the mic to you.
How do you find the 3 top rehab?
I'm gonna tell you. I'm gonna tell you in just a minute.
So also if you have a question, just raise your hand because we have these wonderful volunteers on either side, so they'll get the mic to you, but you need to raise your hand.
Yep. Keep a copy of your discharge paperwork. You're gonna get discharge paperwork from both the hospital and the rehab. And it always has tons of information on there that's good to have. When you arrive at rehab, you want to notify the social services department that you want to be a part of your care conferences. Those care conferences usually include the social services department, the therapy department, and the nursing department. And they are speaking on your behalf. So if you are not a part of that conference, you just hope for the best, I guess. And what those conferences are, they talk about your progress, or your lack of progress sometimes, and then your discharge plan. Make sure you have a solid discharge plan that includes needed equipment like wheelchairs or walkers, possibly having caregivers at home with in-home care, and outpatient therapy services. How to choose a skilled nursing and rehab. Use Care Compare. Care Compare is a website online. It's a CMS website, and it is great. You can use it for all types of different medical entities, hospice, home health, doctors. So you can review and compare the facilities, and it will actually tell you their star ratings. And those star ratings are based on their inspections, their staffing levels, and any kind of deficiencies or penalties that they had received in the last few years. Ask friends and neighbors. Most people have already been through this healthcare journey, or they've been close to someone who's been on this healthcare journey. It's great to get advice from people that you trust.
There are multiple Care Compare websites that come up for that search, so which one are you referring to?
The one from CMS.gov.
Okay.
Yep. Yeah, I'm actually glad you brought that up. So if you don't go to the one on CMS.gov, you can fall into a marketing trap. And then you enter your information and all of a sudden you're getting 20 calls a day from different facilities trying to recruit you.
And CMS is the Center for Medicaid Services.
Also good, thank you. Make sure that the rehab accepts your insurance. So you can choose the top 3 and none of them will accept your insurance. So then you have no backup plan there. So call ahead of time and make sure. Most of us have HMOs, Kaiser, IHP, Desert Oasis. They all have specific contracts with different skilled nursing and rehabilitation. So you want to make sure that the ones you're choosing are the ones that you're even qualified to go to. And then a reminder to choose those top 3. That way you have some backup plans. 1 second.
So,
Wait,
are
one
you
second.
recommending that you call are you recommending that we call our healthcare provider to see who they cover?
Most of the time, your primary care doctor doesn't know.
No, but I mean, I have DOHC,
Oh.
but it's through HelpNet.
Yeah, that's fine. You can call Desert Oasis, and they'll give you a list of rehabs that they have a contract with.
Okay.
Yep. And feel free to tour as well. When I ran skilled nursing, we had a lot of people that would come in and tour and say, I'm expecting to have a serious surgery in 6 months, and I want to do a tour of the facility. And you can pop in and do that during normal business hours and check the facility out for yourself. I added this slide because it's one of the things I feel like people get the most confused about when it comes to home care. There is home health, and then there is in-home care. Home health, a referral is needed for that service. And insurance covers that for the prescribed duration. Nursing services such as wound care, therapy services, including physical, occupational, and speech therapy, and those can all be performed in your home, or if you live in a facility like an assisted living, which is also your home, those services can be provided there. In-home care is private pay or long-term care insurance. Sometimes VA, people will have VA care and attendance, things like that. And that provides caregiver services. So that would be someone like an assistant almost. They're gonna come help you shower, maybe meal prep, housekeeping, things of that nature. And then in-home support services is a program. Go ahead, Stephen. He has more.
Yeah, so I actually work for IHSS, and one of the things you need to understand about them, I mean, sometimes you don't have a choice for more of a private care situation, or sometimes you just need IHSS because you need somebody to come in and cook or clean or something like that, but not serious medical care. It's a service in the state of California. It also provides pretty much no training at all to their voice. Now seriously, I took care of a man who was a thalidomide baby. He had no legs, one arm, and a finger. And nobody told me how to pick him up and put him on the toilet. Nobody taught me how to use a wheelchair. You have to understand, in IHHS, the client that you're taking care of is the one who signs your time slip. So just in understanding it, I mention this only as if you are fortunate to get IHHS, that you manage your expectations. Okay, just say, I'm going to use this person for laundry, cleaning, and cooking. Or I'm gonna use this person just to help me take a shower, once a day, something like that. But manage your expectations, because you're not gonna get the same type of skilled nursing that Renee was just talking about.
And most IHSS qualifications are based on income level, so just keep that in mind as well. But also advocate again for yourself with these IHSS workers. Make sure that you are vocal about your needs. I know a lot of people hate asking for things. So someone could be lifting them completely wrong and it hurts their arm every time they do it, but they don't say anything. So just make sure that you're continuing with this self-advocacy.
For the home health option covered by Medicare, is there such a thing as continuing to get renewals that then sort of inherently become long-term because you're continually prescribed the needs, or is there some criteria where they say no, that now falls under long-term care?
Great question. So for home health, it's usually an acute condition, something like you had broken your hip and now you're back home and they're going to give you 6 months of therapy services. You would not usually get a continuance in that referral unless something else happened. Maybe during that time you fell and re-broke your hip, or maybe you got pneumonia and it really put you back. So they're going to continue the services. But once it goes to long term, then you're probably talking more hospice services.
And the same is kind of similar with when you're sent to a rehab. I know, for example, that my mom was sent to a rehab, and she could only stay for, I think it's 26 days or something like that. Is it 20? I think it's 26 days. We would literally take her home for a night and then check her back in for another 26 days. So these are kind of the peculiarities on some of these services too.
And so Medicare itself will cover 100 days for rehab and skilled nursing. However, if you have an HMO managing that Medicare, it is very unlikely that you will be there for more than 20 days or so. So it's just so vital that when you get to skilled nursing and rehab, that you are putting in as much effort as possible to progress within your condition and get stronger.
Brittany, a ways back, I think under IHSS,
Uh-huh.
you mentioned something was based on income level, so what's that mean?
IHSS is something that the state provides. This is a county thing, home support services, for people who are low income. If you're not low income, I guess they expect that we hoarded away money for this situation. But there, like I said, there are other couple of different avenues. Long-term care insurance will cover caregivers. VA aid and attendance will also cover caregivers in the home. Yeah.
Thank you.
Just wanted to, is it on?
Yeah.
Yeah,
Oh,
keep
okay.
talking.
Just wanted to follow up. I know Brittany was mentioning IHSS workers that aren't really necessarily skilled trained. However, if you're having home health, you can have sessions with your PT or your OT with your caregiver there so they can learn how to lift and transfer or whatever your needs are. So they're getting the skill to make you safe. And then, let's see, And then home health can also provide, they don't necessarily offer it, but they can provide showers through their home health aid. So you don't, if you do not have an in-home caregiver or can't afford a cost out of pocket, and you're concerned about your hygiene because you're not safe to shower by yourself, you can ask for home health to provide that in-home health aid so you can get showers twice, 3 times a week, whatever the need might be. And the last thing, through Riverside County, it's very short term, but they do provide through Office on Aging a caregiving, I don't know how many maximum hours they give, but it's very short term. But if you're scheduling yourself for rehab and then knowing you have to come home after a surgery, or even if you don't want to go to rehab and you'd rather just go straight home, you can try and set that up through Office on Aging of Riverside County in advance to see if you qualify for those caregiving hours. It's kind of a lengthy process to apply, so if you know it's a elective surgery, you can try and do that in advance if you want to come home and not have to go to rehab, or you're fearful after rehab to do that by yourself. You feel like you're not ready. Sorry.
No. And we could probably talk all day just about in-home care and home health. We try to obviously make it time efficient. But yes, a lot of times, as long as it's in your care plan, you can get additional services, but that's why it's so important that you are a part of your care conferences and all these types of things so that you can advocate for yourself and what you need.
So a lot of friends use a friend or family member as an IHSS worker. Can you explain how that works?
Sure. In-home support services, if you do qualify, they'll usually email you or provide you a book like this big with a whole bunch of people who have their are certified to be able to provide the services in your area. Some of those things are so outdated, and so a lot of people choose to have a family or friend become their worker. So you can also do that through IHSS. They would have to do, I believe it's a one-day training on, and that's pretty much when it comes to the time cards and the bookkeeping and that sort of thing. But that is also an option.
We also do the security check and fingerprinting for anybody you get through IHSS.
One of the things that you want to think about with picking an advocate for IHSS is it's not an immediate situation. Sometimes it takes 2 to 3 months to get through the system, even though your helper can start working in advance and then get back paid. But you can pick someone, and if they're not certified yet, they can get certified, but they can start helping with you as per the date that you choose.
Yep.
And then once they're certified, then they get paid back paid for that.
And that's a really important point there, because that's exactly what happened to me. I didn't get paid for 3 months, and unfortunately it turned into a I'm not going to show up tomorrow situation. So again, advocate for yourself. Don't worry about pushing some people's buttons at the state level.
Yeah. Okay, being in the know about your care transitions. With medication management, you always want to keep an updated list, and you can use a system for medication reminders. I know a lot of people right now are using their phones, their special medication reminder apps, and things like that, or you can just do old school pill boxes. But either way, make sure you have some kind of system. Your doctor follow-up, make sure you're scheduling those, that you're prepared for those visits, that you're completing all your visits. And then your personal health record.
I just have the slides are bouncing. Can
You know what? It's the air conditioner.
It's the air conditioner. So it's causing the...
Yeah, sorry.
It is cold. Personal health record, my chart. We talked a little bit about that already. And here's a little snip of my chart. They look pretty similar. You can schedule appointments, message your doctors, look at your upcoming appointments, see your test results, your medications. So it's a really great tool. And then having an advanced care directive. And that's a document that outlines your healthcare wishes. And that's very important to have no matter what age you are.
And that's actually the next discussion we're having with Inland County Legal Services.
And then allergies, like Stephen had said earlier, not all the My Charts communicate, not all the doctors communicate. So on the one of the forms that we provided, there's an allergy thing at the top, and make sure that all of your doctors are aware of those allergies. And then knowing the red flags, so understanding your condition and how to ask questions. Go ahead.
One of the seminars I learned when I first moved here in 2016, I have a sheet that on the front it has all my doctors, their phone numbers, fax numbers, and my medicines. And on the back I have all my surgeries and stuff.
Yeah.
Medical history.
Yep.
And so I update that, and every time I go to the doctor, I give them a new.
Perfect.
Great.
Yeah.
And it really saves a lot of form filling and stuff.
I'm sure. Yeah, and that's a great way to self-advocate. Yeah.
I'm going to circle back for 1 second too. When we're talking about knowing your medications, keeping your prescriptions updated, one of the things you have to know is sometimes when you move from care facility to care facility, the doctor who discharged you is more than likely going to write the med order. It might be different from when you were in the care facility. So when you go back to your regular doctor, you have to make sure that they know which meds you really are on, because we had a situation with my mom where they released my mom, they had her on a bunch of meds, and I asked the doctor about them, and he was like, well, the psychiatrist recommended that. I was like, wait, you signed it. It's your name on that prescription now. So that's one reason. The other is that every year you should be going through all of your prescriptions with your doctor and your pharmacist. Your pharmacist is like your best friend because they will catch things that your doctor might miss because of my chart or whatever, just naturally. So at least once a year, sit with your pharmacist, and they will talk to you about drug interactions, or oh, I didn't know you went on this works counter to that, or oh, you went on this, don't drink grapefruit with it. So it's really, really important that you kind of put that on your medical schedule every year to make sure you fully go through your med list.
Knowing red flags for your condition, so understanding your condition and how to ask questions. Know things that may be red flags for your specific illness. Maybe once in a while your fingers start to go numb. That can mean nothing and that can mean everything. So knowing what that could mean for your specific condition is very important.
So, in the end, and what does John say, when you're casting off, you might find yourself or the person you're advocating for in hospice services. These are just some tips about hospice services. One thing is that's a little deceiving is that they call they'll order, let's say, in-home hospice. All that means is wherever your home is at the time. So my mom was in a care facility and they ordered hospice services. It was done at the care facility. We didn't bring it her home, literally. So it's wherever your residence is where your services occur. The other thing is that what's kind of great if you're in a living facility, for example, like Stonewall Gardens, and you have in-home hospice, you still have the care that you already had within the facility you're in. So it's almost like double duty, which is quite nice. Asking friends and neighbors is super duper important. If you know anybody who has been in in-home hospice, or a parent or a brother or sister, whatever, find out what their impression was. How did they work with them? Were they sympathetic to your emotional needs? Interview the providers that you have. So if you're going to Stonewall Gardens, interview Brittany, and she's going to, ask all the questions you want. Speak to other people in that facility if you can. I think that's it. Yeah. Oh, and then use Care Compare again to review and compare different hospice providers.
And I also just listed a little clip of what hospice does. I think a lot of people, this is something else people get confused about. Hospice does a lot. They are a great part of the team. Someone who runs an assisted living facility, they pretty much join our team for someone who's at end of life. So they provide medical care, emotional support, spiritual care, and family guidance as well. So for guidance for your loved ones. Hospice is a fantastic service.
And we're also going to touch on that later on when Marjani speaks about the use of a death doula, which is different than hospice. They have different concerns, and so that will be covered as well. Mostly focusing on spiritual and emotional concerns.
Okay, advocacy in hospice. So identifying your advocate if you haven't already. I hope at that point you would have. Choosing a hospice provider, again, using that Care Compare, asking friends and family. Maybe having private caregivers in there through IHSS or private pay means. Your medications and equipment will be managed by hospice, but you want to make sure that you're asking for what you need from them. So if you need something else, they'll give it to you, but they have to know. So make sure that you ask. And then identifying a funeral home or cremation services. Checklist for after death. It's great to have an after-death checklist. This ensures that you and your chosen family are respected in your final wishes, whether that's a will or a living trust, or any of those types of things. There is a presenter later on today, and right after, that will be going into more detail about how to prepare for after death. Oh, there we go. And if you forgot who I was already, my name is Brittany. I am the executive director at Stonewall Gardens Assisted Living here in Palm Springs, and then I'm also a care navigator for Triangle Care Management.
You know,
Down, Steve.
regarding the last comment you made.
Yes.
I have an executor and then a secondary, the first one can't do it. We all three went to the bank and had them sign on one of my checking accounts so that there would be money for them to pay for things.
Right.
And so that's a good, everybody should do that here too.
Absolutely.
That's-
Or prepay.
Yeah.
So, you know, obviously a lot of people will prepay for their funeral services.
Well, I've done that, but in
Yeah.
case there are bills and stuff that
Oh,
come in.
absolutely. That's all going to be part of your after-death checklist. You want to make sure somebody has access to funds.
Right.
Someone you very much trust has access to funds, you know, so they can deal with those types of things.
Sarah? Yes, Secretary.
Yeah, so I'm curious, Brittany, what do all those letters stand for?
Oh, I would love to tell you. Those are my fancy schmancy abbreviations. LNHA, I'm a licensed nursing home administrator. And then RCFE is residential care for the facility for the elderly. So I am an assisted living administrator as well. Yeah, that's what.
What passions are you going to go for?
I'm actually getting my master's in speech language pathology.
Oh, good.
Wow. Yeah. Yep.
Any other questions about this segment? All right.
No?
Well, thank
Okay.
you.
Thanks, guys.
And now we know what all of those letters stand for. Another round of applause, please, for Susan. All right, so next, now that we have our toolkit, there are other things that we have to get through. I'll let you. You get to click the clicker.
Here we go.
There are other things that we have to deal with, and they happen to be legal issues. And to help us get through that, we have Warren Snyder, who is a staff attorney with 8 years of experience in Inland County's legal services, where he has worked in their health law team since 2019. And he is standing by over here, ready to take the stand. Yes, he is a member of the health law team. He assists low-income, elderly, and marginalized clients obtain insurance coverage and access medical services and resolve medical debt. And in addition to directly assisting clients, Warren also represents the team at community outreach events like this one, and in collaboration with other public interest programs throughout the community. Warren Snyder, Esquire. And Warren is joined by Levi C. Colonna Bevis. Is that Bevis or Bevis?
Bevis.
Okay, I'm sorry, I'm butthead, I got it wrong. Levi C. Colonna Bevis is an Equal Justice Works Fellow sponsored by Fenwick and West LLP and Inland Counties Legal Services. He oversees the HIV Project at ICLS, which is seeking to improve access to legal and medical services for people living with HIV in San Bernardino and Riverside counties. The HIV Project specifically seeks to enhance access to legal services in rural and historically underserved communities. Levi joins ICLS, has been there since 2025. He's a graduate of Sandra Day O'Connor College of Law at Arizona State University. Please welcome Levi C. Colonna Bevis. Welcome, gentlemen.
Okay, so my name's Warren, if you didn't catch that. I'm just going to do an intro to Inland County's legal services, what we do, a little bit on healthcare complaints. Is that better?
Yeah.
Better. Perfect. Sorry. Okay, my name is Warren Snyder. I'm a staff attorney with the healthcare team at Inland County's Legal Services. I'm going to introduce Inland County's Legal Services, talk about some of the things we do, a little bit about healthcare law, a little bit about HIPAA regulations in particular, and then I'll turn it over to Levi, who will talk about advanced healthcare directives. We are attorneys, we are not your attorneys. Anything we say is general information, it is not legal advice. ICOS, we're a nonprofit. We serve residents, senior residents and low-income residents of San Bernardino and Riverside counties. That's all that. These are some of the areas of law we can assist people in. We have an elder law team that does elder abuse restraining orders, estate planning, powers of attorney, consumer issues. We have the healthcare team. We help with pretty much everything healthcare related other than malpractice suits, things of that nature. We have a public benefits team that helps with all sorts of Social Security, SSI, SSDI, food stamps, any other public benefits that I'm missing. Consumer law team, they do consumer debt relief, defense, bankruptcy. Housing team that helps with all sorts of eviction defense or other habitability issues. Immigration team that helps to adjust status, naturalization, deportation defense. Tax and bankruptcy team, we have a family law team that helps with divorces, restraining orders, custody and support issues. We have a systemic and impact litigation team that looks for issues within our counties that aren't being properly addressed by the counties, such as general relief funds. When they weren't paying that out, we sued them to make them do that. A lot of housing plan issues where they agree to build a bunch of housing and then don't do it, so we sue them. We have a small business administration team that helps people set up small businesses, gives advice on that. We do guardianships, we have a name gender change marker clinic, and we do criminal record expungement clinic. Okay, on to healthcare. So basically any time that you're unhappy with something your health insurance is doing, you can file a complaint. And that might be that your doctor says you need a service and the health plan says we're not going to pay for it. Or you might not be able to get an appointment with your doctor, or your doctor might be 50 miles away. All sorts of things. You can always file a complaint. Sometimes they're called complaints, sometimes they're called grievances, sometimes they're called independent medical reviews. It just really changes between health plans, between Medicare and Medi-Cal. It can get confusing, but in general, you can file a complaint. And yeah. Once you do that, your plan typically has 30 days to respond. We usually advise people to try and do it in writing, either online or on paper, because when you call in and you tell member services that you're unhappy, you want to file a grievance or a complaint, and then you come back later because they didn't do anything, it's a little trickier to show that those 30 days have passed, or that you actually filed a complaint and not something that looked a lot like a complaint that you thought was a complaint. So always in paper, and you have a record of when you did it. You can always do informal steps first, like talking to your doctor's office if you're not happy with the services, talking to your health plan member services, talking to your nurse case manager. If you don't have a nurse case manager, if you're in Medicare and Medi-Cal, you're entitled to one. So ask your health plan about it if you're having trouble coordinating your care or getting appointments set up or things like that, and they will assign you one. Okay. Yeah, so normally you file a complaint with your plan, they have 30 days to respond. If they don't respond within 30 days or you are not happy with their response, then you can escalate it to either the Department of Managed Healthcare, or if you have Medi-Cal, you can take it to a state fair hearing. You can take it up to Medicare if it's a Medicare plan. If it's like a discrimination complaint, that goes to the Civil Rights Department. Pretty similar process though, you just file with them, they'll investigate. You can file quality of care complaints if you're just like, my doctor's office is being rude to me, or they said they won't want to see me anymore. things like that. You just feel like I showed up and they didn't listen to anything I said. They're not helping me get better. You can file those with the medical board, the nursing board, and they investigate those. They do not investigate like payment disputes or anything like that. HIPAA. So the Health Insurance Portability and Accountability Act, or HIPAA, is a federal law, and it says when covered providers can access, use, or disclose your protected health information. There's another California law that's a little broader. It's called the California Confidentiality of Medical Information Act, and it prohibits providers, service funding contractors from disclosing medical information without getting your authorization first. So HIPAA only covers direct providers like doctors, pharmacists, things like that, health plans, and then health clearinghouses, who are people who basically take the bills from your providers and turn them into something that will get paid. And, whereas California's law is broader, basically anyone who does something designed to hold on to your medical information, they fall under that. They are a healthcare provider under that law. What is protected health information? It's any information, including demographic data, that both relates to your physical or mental health or condition, the provision of your health care to you, the past, present, or future payment for health care to you, and that has some information by which it could be reasonably believed that you could be identified by it. So if it's completely anonymized, it's not PHI, but if there's something in there like your age, or your ethnicity, or your address, obviously, or your phone number, then it becomes PHI. There's a lot of times that they're allowed to disclose your private healthcare information. Obviously, they can always disclose it directly to you, and they're required to. If you ask for like your statement of benefits, you want to see, hey, what did they bill me for? What did you pay? What did you not pay? They got to turn that over. They can't say, no, we're not going to tell you what we did because of HIPAA. Anything related to like treatment, payment, health care operations, I feel like that one's like pretty straightforward. Like your doctor can say, I saw Joe and I did this and please pay me for it to your health plan, and that doesn't violate your health care rights. There are instances where they have to give you the opportunity to agree or object. A lot of times that's like, you're in the hospital. Can we put your name in our directory so people can find you? Can we tell your family that you're here, that you got brought in? Things like that fall under that. You do have to give authorization for those normally. They can disclose the minimum necessary incident to any other kind of approved disclosure. Straight. They can do all sorts of research and public interest kind of stuff, like federal data mapping on like healthcare usage and stuff. That's all pretty limited generally. Okay, hold on. So some of those like limited uses are if the law requires them to turn over information. For public health activities, that's like flu tracking and stuff like that. If you're a victim of abuse or domestic violence and they're a mandated reporter, they can turn it over for those reasons. For oversight activities, the Department of Managed Healthcare is looking at what kind of waiting times people have and things like that, and quality of care. Are people happy with their care? Are people getting care? They can turn over information for that when required by a court, when required by law enforcement.
With the public health concern?
Yeah.
If you're diagnosed with something that's a public health concern?
Not necessarily, but
Raise your hand when you have a question. And one of the volunteers will come by with a microphone so everyone can hear it. He has a question.
So my question was, thank you, John.
You're welcome.
If it's a public health concern that your information needs to be disclosed because, for example, how many people have been called because somebody they were with passed an STI.
Yeah.
So that is an exclusion to HIPAA?
Steve, could you repeat it closer to the mic?
So his question, his question was essentially like, if someone you've been with is diagnosed with an STI, can you be notified? I don't know the answer to that offhand. I will find out while Levi is talking. Do you know?
Yeah, doctors, well, the doctors can know, and some, like syphilis, legally need to be reported and tracked, so the health department.
Right.
Track down your partner. So that's why they want the information, but it's completely anonymous, so don't feel like they're gonna say, you know, Steven said, you gave this to me and we're tracking you down. But it's, syphilis, I don't know how it works for HIV, but I know the syphilis is one, so it can happen.
Yeah, I'm sure they track the overall anonymous. I don't know about. Yeah, I will give you a good answer by the time we're done. If someone dies and they need to identify them, things like that. If you're an organ donor, they turn over information regarding you after you pass. Some research stuff. You know, with health and safety threats, we were just talking about, essential government functions, and then for workers' comp cases. If you think there's been a HIPAA violation, you can file a complaint. You can do it mail, fax, email, or there's a complaint portal online at the Office of Civil Rights. It has to be within 180 days of when you believe that the HIPAA violation occurred. With the CMIA, California's law, you can pursue a civil action directly against the provider if you think they've violated it. And that's about all I have. Is that you, Levi?
Okay. Thank you, Warren.
Thank you all.
Thank you so much, Warren. Great. And thank you so much again for having us here. Like we mentioned before, my name is Levi Colonna-Beavis. I am an Equal Justice Works Fellow who is new to ICLS. We have a new project in which we are seeking to connect people living with HIV to medical services and legal services, particularly in rural areas. But we are here to talk today a little bit more about advanced healthcare directives. And I'd encourage you to, if you want to follow along, we're going to be kind of diving into the specifics and just some key considerations for this document. It can be found under the yellow tab 3 at the very end of this presentation of the slides. And thank you again to Jeff and Steven for providing all this information in these great binders. So what is an advance directive? An advance directive is a legal document that effectively ensures that you can put someone that you trust in charge of your healthcare decisions in the instance that you are not able to make those decisions for yourself. So if you're incapacitated, if something happens, you're not able to communicate your medical preferences and your choices, this is the person that would be able to make those decisions for you through this document. And this document has two key components. The first part is going to be your durable power of attorney. This is where you select the agent, the person who's going to be making those decisions for you if you're incapacitated. And they can basically carry out your healthcare wishes. If there are no specific healthcare wishes, and we'll kind of talk a little bit more about this throughout the presentation, then this is also the person that will be able to make those decisions that either you have shared with them outside of this document or that they understand you well enough to know you would likely want in those situations. So I'm going to emphasize this a lot throughout this presentation. It is really, really, really important that when you select someone as your agent, you want it to be someone that you trust, someone that you feel is going to have your best interests in mind, is going to act on your best behalf while they're carrying out these decisions. The second part of your advance directive is going to be your living will. And this is where you're going to outline your specific preferences for any number of medical situations, any preferences you have post-death as well. This is where you're going to be putting in a lot of this information. And you can be as specific as you want, or you can leave it a little bit more vague. But overall, these two components will comprise the advance directive. So who needs a directive, and why do we need one of those? There's often this perception that advance directives are only for older adults, and that is simply not the case. Everyone needs an advance directive. medical emergencies and medical crises can happen at any time to any person for whatever reason. And there's other considerations too, for instance, that might involve incapacitation. For instance, if someone is arrested and goes to prison, if someone is deported, you want to make sure that your loved ones are able to make those healthcare decisions for you if in the instance you're not able to make some of those decisions for yourself. So again, this can happen to anyone at any age, so it's important that we all have one. And planning now for your future health concerns and crises is going to not only help remove that stress from your loved ones in that situation. So instead of, for instance, if a medical crisis happens, them spending time having to figure out, well, who is going to be the person to make those decisions? Who's the one that's going to make that decision? Are there multiple people that are going to make that decision? This document helps you ease all of that concern by selecting someone who is going to be the designated person to help you make those decisions. In addition to avoiding any confusion, if doctors are coming to someone or if your medical providers have questions or concerns, they know who to go to, they know who to contact, and that just alleviates a lot of stress and concerns during stressful periods. So this is where I'm going to invite you to join along with the documents. You'll see there at the end of this presentation, I start here on page 2. So the first page is basically just key instructions and statutory language that you can find in the probate code. It's probate code section 4701. If you're interested and you want to find this later as well. This is important to kind of also read through on your own, and I'd encourage you to do that because it outlines some of those key concerns and things and just considerations that you may want to know before you start filling this out for yourself or a loved one. And it also lets you know kind of how this process works. But I'm going to go ahead and get started here on part 1, which is page 2 of the Advanced Healthcare Directive form. So this is like we mentioned before, the key durable power of attorney. So this is where you are going to be designating your agent to make those healthcare decisions for you in the instance that you are incapacitated. You'll see there that there's a good bit of information that's listed. Primarily for that first part, you want to make sure that when you list your agent, you have some way for medical providers, for other folks who may need to get in touch with them about your decisions in healthcare. You want to make sure you have their phone number, their physical address, some way for them to get in touch with them. That is very, very important. I also want to note that you can name almost anyone, including people who are not related to you, as your agent. And there are a very few exceptions that I've listed right here below. It's also listed in the Advanced Healthcare Directive form. So this is just something to note. You cannot, as an agent, name your supervising healthcare provider, an employee of the healthcare institution where you receive care, so that can be a hospital, private care facility, whatever that may be. You also cannot name an operator or an employee of a community care or residential care facility. This is primarily to prevent any potential abuse or situations where there may be a conflict of interest, right? To protect you and to protect your interests as well in that. There is an exception to this because the law likes to make things a little bit more complicated. But the exception to these specific limitations are that if one of these 3 situations applies, but that person is an identified party, the identified party is your relative or a coworker, you can name them as your agent. So that is something you just want to be careful of. If, for instance, you are working in a healthcare setting and you want to name a coworker, generally that could be okay. It may also be helpful to think about other folks who might be able to be an agent as well in that capacity, just in case there are additional questions or concerns down the road with this. So just be aware of all of those situations there. I also want to point out here that you can, of course, name one agent, but there's an option to name a few alternate agents. And it's very much recommended that folks go through and name at least one alternate, because if, for instance, your agent is incapacitated, if they're not able to make those decisions for you, if they're out of the country and can't get to the medical providers to help you with those decisions, then you're going to want someone else who may be able to jump in and support you in that process. So that is always helpful there. You do not have to list an agent to have a valid Advanced Healthcare Directive. So I do want you to know that as well. It is not required that you have an agent. However, it is very helpful to have someone who can advocate on your behalf to medical professionals, to providers, to other folks around, and just be able to make those decisions for you. And again, that's why it's really important to name someone that you trust in this process. If there is no agent listed, generally medical providers are going to go through a list of people in the following order to determine who's going to be that person that's going to make those decisions. First, they're going to look to see if there's a spouse. If there's no spouse, then they're going to go and look to see if there's a parent. If there's not a parent, they're going to look for adult siblings and other blood relatives. And if there's no blood relatives that they can identify, then they're also going to start looking for people who have an intimate personal relationship with you. And again, it's important to think about when you're naming your agent, someone that you trust, because sometimes some of those folks may not be people that you want to make healthcare decisions for you. So this gives you the opportunity to name someone that you want, that you know is going to put your best interests first, as opposed to letting medical providers or court determine someone who you may not want to make those decisions for you. So this part is important as well. So we're going to continue. Oh, yes.
Does that have to be part of, on this form that you have here in the binder, does this have to be in your will? Or can you just list it and put it with your will?
The form itself or the agent?
The agent.
The agent? Okay, so the agent is not someone that should benefit from you in your will. So
would your executor be in one of the people that would be listed?
let me get back to you on that. I need to look into that a little bit. I generally, with this and both the agent and the witnesses, there are certain limitations in terms of the folks that you can name. I would say if they're not one of those three situations there on the right that we've mentioned before, but I would also be careful about folks that you've listed in your will, because that may present a potential conflict of interest, right? So to avoid those situations, it may be helpful to name like a trusted, non-interested friend, someone that can really be your advocate, but may not necessarily benefit from a will, if that makes sense.
Yes. Also, you know, you might, if you know you have a planned medical procedure.
I can't hear you.
Sing out, Louise.
Sing out, Louise. Project. No, don't sing. Talk.
Okay. So, also, you know, if you have a planned surgical procedure, you know, planned stay in the hospital, it's always good to keep copies of it, because the first thing they're going to ask you is if you have an advance directive. And to answer your question, Alan, I actually keep all that stuff together, like my trust, my will, all that in one place, that somebody knows where to find it.
Well, I have mine in a safety deposit. I have the original in a safety deposit box, but I was told the minute the bank finds out you're dead, that they lock the safety deposit box. So I have an executor and second option, and they have keys, and so I told them, run to the bank and get that will.
Well, I think that's a great point, and I appreciate you raising that, and that it's really important, and we'll talk about this a little later too, that the person you name as your agent definitely needs to know where this power of attorney or this advance directive is, because they need to access it. It's also usually helpful to talk to your providers and say, hey, I have an advance directive. There may be someone making this decision for me. Know it's there. If you need to provide them a copy, that can be helpful. It's not required. But it can just be helpful to let your provider know as well that there is someone who can make those decisions for you and who have that document, so they can also assist you in that process.
But I have a duplicate at home as well, but the original is in a safety deposit.
Absolutely. You're prepared. Yes.
So you mentioned the conflict of interest. How does a spouse fall under that? Because a spouse, you may want to put on his list, but they may be in your will as well. Do they fall into that conflict of interest, or how does that work out?
So again, for the agent, you want to be careful and think about those things. But to my understanding, as long as they're not in one of these three situations, that should be okay. It just may be something that you want to consider, right? And that's just something we want to raise for you. So these are the three situations that by law you cannot name the agent from. So otherwise, it should generally be okay. But again, I would just be careful of that. So just be cautious. Okay. Any questions? Okay. All right. So moving on to sections 1.2 through 1.5. So again, unless specified, the agent that you assign is able to make pretty much any and all healthcare decisions in the case that you are incapacitated. But that is only in the case that you are incapacitated. If you name an agent, and then we're going to talk about this in just a moment, there are situations where you can either make your advanced healthcare directive immediately effective, or you can wait until you become incapacitated and then it becomes effective. So when you're naming this, if you make it immediately effective, if, for instance, you go to the doctor, you make a choice to have a procedure done, and your agent says, oh, I don't know about that, you can still override the decision of your agent while you have capacity, but you have to have full capacity. So that is just something to note with your agent to be aware of. There are also some limitations to psychiatric care. There's a separate psychiatric advance directive that will also outline specific concerns or preferences you may have for psychiatric care. We're not going to talk about that today, and that is not my area of specialty. So I would just encourage you to just know that's there. You can definitely look into it. And we will also continue down this process. So kind of like with the first point here, you can see that the agent's authority, you can specifically outline the authority that they have. It says, my agent is authorized to make all healthcare decisions for me, including decisions to provide, withhold, or withdraw artificial nutrition and hydration and all other forms of healthcare to keep me alive, except as I state here. So again, if you have certain preferences, this is where you can limit the scope of your agent's authority over what decisions can be made, if certain areas should not be made. That's where you're going to put that. Like I mentioned before, generally, and without checking this box in 1.3, the standard is that these healthcare directives are not effective until you become incapacitated. So as soon as you fill this out, you complete everything, you have witnesses sign it, you get a notary, all those things, that doesn't make it effective immediately unless you check this box here in 1.3. So that is just something to consider. Otherwise, it becomes effective at the time you become incapacitated as determined by your primary care doctor. 1.4 just kind of outlines the requirement that it's understood that the agent is going to act according to these wishes. If they know of any other concerns that are outside of these wishes, you may have shared with them in a conversation. They will basically, they're bound to act in your best interest and adhere to those wishes as much as they can. 1.5 is also going to concern specific post-death authority for your agent. So this concerns tissue donation, organ donation, authorizing an autopsy, those kinds of concerns. We're going to talk about this a little bit as well. You can also, as it states here, mention this in part 3 of the form when we discuss that. That section is specific to tissue and organ donation and burial matters and concerns. But you can name them in both, or here or there. So if you want to name certain, for instance, if you have certain processes that you want undergone after death, this is where you would outline those as well. And I wanted to just note 1.6 here, the nomination of a conservator. So in the instance that you do not name an agent and you don't have a healthcare directive, courts will sometimes seek to name a conservator, meaning that person, the conservator, kind of is the agent that would make those healthcare decisions for you in the instance that you have not named an agent. And that is, again, they will name that only if you become incapacitated and if there's no one to make decisions for you that they can identify. So the court will sometimes look at that. Generally, under those situations, the court is not going to consider your preferences as a matter of death. And again, at this point, you also are incapacitated, so you can't share those concerns. So this document is going to help you because the person that you name as your agent is someone that if you become incapacitated and there is a need for a conservator, that automatically is something the court can consider as your conservator, is your agent can be considered as your conservator by the court. That doesn't mean the court is going to absolutely make that decision and nominate that person, but they do consider that generally, and it's helpful to have that. Yes?
What's the difference between your designated medical power of attorney with a broader power of attorney? Doesn't that supersede a conservator?
So the key difference is going to be the Advanced Healthcare Directive specifically applies to your healthcare choices, your concerns, those matters around healthcare needs generally. The power of attorney tends to be a little bit more broader and usually includes things like financial powers as well, concerns over estates, property, that kind of thing. So they are overlapping in some capacities in terms of the general agency, but they also concern slightly separate areas. So it is helpful to have both. And generally just to make sure all of the bases are covered, that you've got someone who can make decisions for your financial side as well as your healthcare needs as well. And this one also specifically applies if incapacitated. So that is just, I think that's the key difference there. thank you for that question. Let's see. I think that's everything for this. Okay. So moving into part 2 here. These are specific instructions for healthcare, and this form is going to specifically outline some situations that they would, if you have preferences, this is where you're going to designate those. And I want to start by just sharing too that we recognize that this is a very difficult conversation to have in certain instances. It's a very personal and sometimes very difficult decision to make, a very personal conversation to have with folks. So we recognize that this can be uncomfortable, but we also encourage you to have these conversations early so that the person and the folks around you who will be making some of these decisions or folks that you trust know what you want, know what your preferences are. And it also makes those conversations a bit easier when you can have them earlier, make space for that, and continue to build on those conversations as you go. So again, it's important to have conversations around some of these matters with the folks that you might be considering naming as your agent, just so again, they're aware. And being able to designate those makes the process a little bit more smooth as well because they know what your preferences are. They can advocate for those for providers and other folks that may need this information as well. And I also want to share that for part 2.3, it may be helpful to include some other specifics. So any allergies to medications, any medical records that may be under a different name, pre-existing health conditions that a provider needs to know about, and other like burial, funeral preferences. Section 2.3 is where you can put in all of those concerns, wishes, any areas of importance that you feel that the medical provider needs to know or your agent needs to know. This is a great place to put that. It's also important to note that at the bottom you can add additional information as needed. So if you have additional things that go beyond these 2 lines here, you can add an additional page and those will be considered as part of this as well. Okay. So part 3. So this part, it does indicate that it's optional. And again, kind of like we mentioned with section 1.5, this is an opportunity for you to input your specific wishes around organ donation, tissue donation, and other areas in that way. So if you have these specifications, you can put those again in part 1.5. You can put them here. If you want to put them in both, that can be helpful too. But having them here in this section 2 can be helpful because this is specifically for organ and tissue donation. It's also important to note that if this section is not completed, that does not indicate a refusal to donate. So generally what's going to happen with that is upon someone's death, the state is going to look at a few different databases to determine preferences in terms of organ and tissue donation. So some of these might include an advanced healthcare directive, if you have one of those. They'll also look to Donate Life California. So this is the statewide database that's going to have your preferences there. And so if none of that information is present, and if you don't have an advanced healthcare directive, then the agent or someone that they appoint to be your conservator will be the person making those decisions. So having a healthcare directive can be helpful in making sure that your specific wishes are honored and noted there.
Yeah, well, one thing I wanted to add about organ donation is that there is now, it's now legal for people with HIV to donate their organs to other people living with HIV. It's called the HOPE Act. It's been around for a little while. So don't be afraid to put that down. Put yourself down as an organ donor, even if you're HIV positive. Thanks.
Thank you. All right, part 4. So part 4 is completely optional. If you don't fill this out, it's not going to invalidate the healthcare directive, but if you have specific primary care physicians that you want listed, this is the place where you can list those physicians. You'll also note towards the bottom of this section, there is also an opportunity to present a second alternative physician in the instance that your primary physician is unavailable. Generally, again, kind of like with your agent, it may be helpful to provide that additional alternative in the instance that your primary care physician moves, retires, or something like that, or they're just not able to contact the medical provider in the instance you're capacitated. So it's helpful to list a couple folks here, but again, it is not required in any capacity.
So I would also add to that if you have a physician that you want in the hospital and stuff, make sure that your primary has privileges at whatever hospital that you would typically go to, because regardless of them, they'll be informed, of charts and stuff like that, but they're not going to be able to physically visit you out in a medical capacity.
Thank you. Okay. And with that, that brings us to, oh, I'm so sorry. Yes.
I didn't really understand his section. I didn't really understand what he was just saying.
Oh, so he was basically saying that if you list a primary care physician in this section, you want to make sure that your doctor is able to access that hospital and be able to also be there and assist you in that process. There are certain procedures in certain medical settings where certain doctors may not have privileges to assist in the care. So it's important to also think about those considerations and being able to make sure that your doctor either is aware of where you might be going for care or talking to them too about where they might be able to assist in care and providing that for you. Does that help? Okay.
So just to add a little bit to what you're talking about right now, specifically to the gentleman's point earlier about where you keep your documents. Many times if you've been involved with home health or even at your doctor's office, you may have been asked if you want to have a DNR order, a do not resuscitate, or a POLST, which is the physician's order for life-sustaining treatment. So you want to make sure that you're keeping both of those documents updated along with this one so that there's not a conflict. So if you have your pulse and your DNR in your refrigerator and you fill this out and you fill it out differently, then you're going to need to update your pulse and your DNR so that they match. So that, I'm assuming this supersedes because it's a legal document, but to avoid conflict, make sure you have those updated. And if you don't have those, maybe we can talk about it on our panel later, Trent. Excellent, yeah. So just that point.
Yes, thank you so much for raising that. Yeah, it is very important to make sure that your medical documents all align. This again just will help you when you're naming your agent. They'll have clear instructions. Your providers will have clear instructions. They'll know what to do. There won't be that confusion. So keeping those documents in line is very important. So thank you so much for that point. Okay. Oh, one question here.
So I know you talked about the durable power of attorney. Now, are there multiple? My understanding is there's a healthcare power of attorney and a durable power of attorney. You can have either one or both, right?
Yeah, so this document would be it is overarching for healthcare, but the first section of that in designating your agent is considered the durable power of attorney. It is also important to note that, again, kind of like we mentioned there, this one is specifically for healthcare. There are other powers of attorney that impact other matters. So that would maybe for like financial matters and those kinds of things. So again, it's helpful to have all of those just to make sure that all aspects of your care are covered for. But this one is particular to healthcare, if that's helpful. Okay. So this brings us to the final two sections that you're going to see, and these two parts are really important. So this is going to be the signature component both for you, and this is also going to be where you will either provide two witnesses or you will provide a notary. So you'll go to a notary and potentially get it stamped there. So notarization, it's important to note, would generally come with an additional fee, and you would also need at least one form of government issued ID to receive a notary's services. So that is just something to consider. If you use witnesses, it is important to note that your agent cannot be a witness. So it's really important here to make sure that you are, and this also is where if you have someone named in your will, they cannot be a witness for you. You're going to need someone who is not a witness, someone who is not named in your will, like an uninterested friend, for instance. And uninterested in this context means they're not benefiting from your will or your estate. So you want to think about folks that you trust that may not be, you may not be leaving things to in your will. Those are folks that can be witnesses here. Ideally, again, your witness should be someone that's a non-interested friend. And you'll also see a lot of these instructions right here in sections 5.3. So that kind of outlines like the specifications for what you're signing, what they're signing. Again, they also cannot be, your witnesses cannot be your individual's healthcare provider, an employee of the healthcare provider, an operator of the community care facility, an employee of an operator or of the community care facility, or a residential care facility employee or operator. So again, those same agency requirements in terms of who you can't name as your agent also applies to witnesses, with the exception that your agent also cannot be a witness, if that makes sense. There's also 5.4, you do, according here to California law, you need at least one of your witnesses, preferably both, to sign this additional attestation here at the bottom for this to be a valid document. Now, Part 6 is a very specific special requirement. It only applies if, in completing this document, you or a loved one is a patient in a skilled nursing facility. And there's the definition there of a healthcare facility that provides the following basic services: skilled nursing care and supportive care to patients whose primary need is for availability of skilled nursing care on an extended basis. In that instance, you would either need your patient advocate or the ombudsman to sign this aspect right here. It's a very narrow situation, but just something to be aware of as you're completing this as well. Okay, so just some key things to keep in mind, like we've discussed here. It is really important to choose someone you trust. You're going to be able to make all of the medical decisions for you in the instance that you are incapacitated, especially if specific wishes or preferences are not outlined in this advanced directive. So it's really important to choose someone that you know will have your best interests in mind and be able to act on your behalf. You also, like we mentioned before, and I appreciate this being raised as well, it's really important for folks to know if they're being named as an agent, where is your advanced directive? They need to be able to access that in the instance that you are incapacitated. It may be helpful to share a copy with them just so they have that on hand if in case it's needed. But also just knowing where those documents are, how they can access them is very important for this as well. You can include language in your directive that also prevents certain people from learning about certain medical information or your passing if you choose that information as well. So that can be a component in the other wishes in that 2.3 section. That is also a place where you can list, for instance, if you don't want someone to know certain information about you or have access to that information, you can list that there. And generally the healthcare providers, unless it's absolutely necessary, will honor that wish and make sure that is taken care of. You also, like we mentioned before, want to talk with your doctor in advance about this. I know these conversations can be uncomfortable and difficult, but having some of those conversations in advance will, one, make sure your provider knows that there's also someone who may be able to help in the instance that you are incapacitated, and they can also talk you through your current health and help address any concerns that may increase the risk of incapacity down the road. So this will just help you also in your own risk assessment, if you will, to kind of think through your future, make sure you're planned and prepared, and that you are putting yourself and your loved ones in the best position possible. So again, I also wanted to note too, while it can be helpful to have an attorney complete this document with you, it's not required. This is something you can do entirely on your own and it still be completely valid as long as you have those key requirements that we've talked about before. So in the instance though that you do need legal assistance, Inland County's Legal Services is able to assist folks residing in Riverside and San Bernardino counties. We do have eligibility requirements, and so these are specifically imposed by our grantors and our funders, so we cannot guarantee legal services to everyone that reaches out, but some of these eligibility requirements involve income, county of residence. We can only work with folks in Riverside and San Bernardino counties, and citizenship-related requirements, and you need to undergo a screening before we are able to render any legal assistance. But again, we have an intake line. We also have a line specifically for seniors and folks 60 plus. And you can also apply online at our website as well. And with that, I'm going to invite Warren back up to help answer any questions. But thank you so much for your time. We appreciate you all being here today.
Thank you so much for your presentation. I just have a question. What happens if you are on a trip to Europe or another country or Wyoming, wherever, you're not local, you're not around your home? What would happen?
So, I suppose I can't answer like the specifics of every single situation with that. Generally, it might be helpful to also, if you know you're traveling, to potentially carry a copy of your advance directive if you have one with you, just to have it on hand. Also letting folks know where you're traveling may be helpful as well, so that if something does happen, a medical provider may reach out to them, and they may be able to assist in that situation, but it would depend, I suppose, more specifically on the situation, which I know is not a very satisfying answer. Questions? Going once? Going twice?
Thank you.
Thank you so much.
Thank you, lawyers, lawyerly folk. Warren Snyder, Levi Colonna Beavis. Yeah, I was paying attention when you were talking about making sure that your directive was not given to those who benefit from your estate. It's like, yeah, pull the plug. Okay, but these are all things you don't want to think about, but we appreciate you kind of making it less scary, and we're a little more comfortable with it. We really appreciate it. Thank you so much.
Thank you.
So, as you're making out your estate plans, of course you could, donate your entire estate to the HIV Positive Aging Research Project, HARP-PS.org, or you could maybe make a donation today at their kiosk. You could do that. We'd appreciate any donations for HARP. And who's hungry? Would you like to have some lunch? Well, I'm looking at the menu and it looks absolutely delicious. Ooh, we've got everything from the fowl to the pork, to the fish in the sea, to the vegetables in the ground. So we have Aspen Mills, we got turkey, we got ham, we got tuna, we got veggies, we got salads. We have chicken too. So enjoy your lunch. It's going to be handed out on the outside courtyard, just beyond where all the booths are. And we will see you after lunch. We will reconvene promptly at 12:45.
Attention. Greetings, hello. Is this the party to whom we're speaking?
Welcome back. How was your lunch?
Fantastic.
Aspen Mills, round of applause. That was so delicious. You know, we had some leftovers, and Charles just came by from the food bank to pick up the leftovers, and they are going to go to our center food bank. And you know what? We have a lot of folks in need, so that's wonderful that that's happening. Nothing goes to waste in this town, that's right. Especially not our best resource, which is people. And so we're glad you're back. We hope you had a wonderful lunch, and we're going to get on with our conference part 2. And this is about the dismount. Planning the exit strategy. Exit, stage right. Who is that? Snagglepuss, thank you. I would like to introduce you to a death doula. A death doula. Now, she doesn't look that scary, does she?
No.
Well, then listen up, because Marjani Bellamorte is a death doula, and she began this more than a decade ago after the loss of a close friend, and has found her calling to end-of-life education and support. And this is after sitting bedside, and I know a lot of us have over the years been there for comfort and for dignity to those who are making their last lap around the sun. We're going to be there someday, and we're going to be called again to be there for someone else. So through independent study, lived experience, volunteer work, Marjani Bellamorte has developed a compassionate approach to end-of-life care, and this has also led her to obtaining her life insurance license, which allows her to better support her clients and their loved ones. And we did want to talk to you. Do you notice that Marjani Bellamorte is kind of jumping a little bit? The screen is jumping because the vibrations from the AC system right above the projector are making it jump. We're not turning it off. So we'll deal with the jumping screen.
Blink more.
Yes, we can handle it. We can handle it.
Don't have a
Just bounce your head, it'll be fine.
Yeah, just bounce your head. Oh, yeah, I can see it perfectly now. I would love for you to put your hands and your hearts and your minds and your attention together for Marjani Bellamorte. Oh, did I do that? Lord.
Hi, thank you so much for having me. Those of you that know my cousin Bridget, yes, we are blood relatives. She's my cousin, so thank you, cousin. And thank you guys for having me. I'm really excited to be here. Forgive me if my glasses fall off. I lost an arm today. So I'm one-armed on the eyes and the body. So, you know. I've been a doula for a long time. I've sat with over 30 people who have made their exit from this world. And I like to do what I call planning your exit strategy. Because having an end-of-life plan can take away so much fear and so much anxiety. Just having the knowledge that somebody knows what you want, that whether you can speak or advocate for yourself, somebody is there to do that for you and give you that autonomy right until your final breath. Up until recently, palliative care and doula work, hospice care, that's all really recent. People don't understand that all started in the 2000s. People have been dying for centuries, millennia. And it's only in this last 20 to 30 years that palliative care, the advanced healthcare directive we heard about, all of that became laws, right? Until then, your family just kind of did whatever the hospital said they were going to do, or your family chose. And once you became incapacitated, you didn't really get a say. So let's talk about what it means to be a death doula. So the International End-of-Life Doula Association defines a death doula as a non-medical companion who provides personalized and compassionate support to individuals, families, and their circles of care as they encounter and navigate death, loss, and mortality. An end-of-life doula advocates self-determination and imparts psychosocial, emotional, spiritual, and practical care to empower dignity throughout the dying process, right? A lot of people, when they're dying, they're scared. They don't know what to do. There's a lot of regrets. There's a lot of anxiety. So having a companion who's with you through that entire process, who isn't your family, you don't have to be like, God, I want Uncle John to know about that one time back in '72, right? But you got your doula there to be like, hey, this one time my cousin and I dropped a bunch of acid and did this thing. And the stories you hear at the end of life, because they don't care anymore. They know there's no more repercussions, right? But what a doula really is your end-of-life companion and your advocate. When you can't speak anymore, when your family is fighting all around you, that doula is that neutral Switzerland person that's there to see your needs are met, their needs, their opinions, their thoughts are not part of that process. So doulas, it's a special calling. You can't walk in and be like, I'm gonna teach you everything about God, and they're like, but I'm a pagan, right? You have to go in and meet them where they are. Where the medical side, they take care of your health care. So what is the difference between hospice and a doula, and why would you want both? You would never have a death doula without hospice. I would never, ever recommend that. Hospice's job is to take care of you on a medical level, and they have an entire team to care for you. Your doula is one person who understands the process and can advocate for you. So what is the difference? You don't go into hospice until you have a prognosis of 6 months or less to live. So unless you're absolutely dying in the last 6 months, you should not be able to see hospice. Sometimes that's sooner. My father-in-law was 97. They put him on hospice and picked him up once a month to give his family a rest. And he didn't die for 3 more years. Strong man. May he rest in peace. They give you a medical care team full of healthcare professionals. So you get your LVNs, your RNs, you get that nurse that's there washing your mom and dad or your best friend. They come, they send a bather, they send a chaplain, they send the doctors and the nurses. Most of you who have been around hospice know they give you that fancy box. Once you go into hospice, here's your fancy box. It's got everything you need in it for end of life. Your morphine, your Ativan, all of the things, right? And when you call us and say this is happening, we're gonna say, go to the fridge, get your box out, go put this in that syringe and go give it to your loved one. And you'll do fine, we'll see you in 2 days, right? So hospice's job is to provide you medical care. They do provide spiritual and other parts with a chaplain and things, but really their purpose is the medical side of your care. Now you can have palliative care added in. Palliative care is comfort care, and that's still very recent too. Once we get a little further along, I'll get into my dates here. Actually, let's just do it now. It's kind of exciting. So June 6, 1999, the right to have palliative care became a law. It's that recent, 1999. And that was where Elizabeth Kubler-Ross came in with this, a study on pain management and end-of-life anxiety caused by pain. So they said, you know what, if you're terminal, if you have advanced illness, we'll put you on palliative care. We'll give you comfort, we'll give you support. That'll be great. You don't have to die to be on palliative care. So palliative and hospice work hand in hand for that, but their job is comfort. I'm not here to give you your spiritual care. I'm not here to give you meaning to your life. I'm not here to help you talk to your kids. I'm just here to make sure you're comfortable. Right? And then in April 22nd, 2005, the Linetti Law came into effect, which allowed you to make the decision to cease any useless treatment. Until then, hospitals just gave you treatment, even if they knew it wasn't gonna, hi, this isn't gonna do anything for you, Steve, but please take all these drugs and be miserable with the side effects. And you could say, no, I don't want to now. But that's only as recent as 2005, that you can say, no, I don't want these treatments anymore. I just want quality. And then in February 2nd, 2016, Claes Linetti had another law that was imposed, and that was for healthcare advance directives, what we just heard about, right? And until then, your healthcare advance directive was just a form you gave your family and your doctor, and they went, okay, cool, that's nice, but what does your son want to happen? What does this doctor want to happen? And then in 2016, they said, no, by law, you have to follow this advance directive. This gives you autonomy when you can't speak, right? So that is one of your most important papers, and we're gonna go through that here in a minute. And then, in addition to that law, they started to allow for full sedation until death. There are some strict guidelines for it, but once you get to a certain point, you can say, I don't wanna do this anymore. This hurts, this is terrible. Put me to sleep and let me go in my sleep like everybody wishes to, right? So now, since 2016, that's a law that you can request that, and with 2 physicians' approval and a few of the other guidelines to follow, you can be fully sedated until you take your last breath and have a nice, peaceful death. And then, death doula, 1960s is when the hospice model started, the doula model started, but none of that really started happening until 2000. And our first real hospice was in 2003 in New York City. Can you guys believe how recent that is? 2003 was the first successful hospice model done by Henry Frisco Weiss. And it was done for the LGBTQ community. And he proved that it was a successful model, and then it became law, and then medical, and insurance started covering it, right? But this is how recent that is. So death doulas are an up-and-coming industry, because who's heard of that? There's birth doulas, there's all kinds of other doulas, but the death doula is newer. And that's because we can see you at any time, months or years before you die. I don't have to wait till your 6-month prognosis. I can talk to you right now, and in 5 years you can say, okay, Marjani, it's time, and I show up and go, I have our plan. We're set, never have to discuss it again, right? The other thing is, hospice gives you periodic short visits. They're often once or twice a week. And that's the actual nurse or doctor coming to do an assessment. Your doula can provide continuous long-term care. I have sat vigil for 3 weeks straight with someone at the end of life. And that gave the family time to shower, rest, go out and have dinner. If there's any change, I know what I'm looking for. I'm gonna call you, right? And that gives them care. So doulas also work well for respite care. You just need a nap. Honey, you've been sitting here 3 days, you got caretaker burnout like a fool. Let me go make you some dinner and go put you to bed, and I'm gonna wake you up when there's a change. Where your medical team isn't gonna do that. They're gonna show up and go, okay, cool, where are you? Here you are, here's all your information, great, we're going home, call us if there's a problem. And not to say that that's bad, that's just what hospice's model is, right? And then Medicare, Medicaid, private insurance, they cover your hospice. Doulas are not regulated, they're not yet recognized in the industry, they're getting there. So everything there is privately paid, and it's out of family pockets, and you're looking at $20 to $300 an hour depending on your doula. I believe, like the company I work for the insurance, GFI, bring Wall Street to Main Street, right? A lot of people can't afford that. So I'm one of the few doulas that will work on a sliding scale based on what you can afford and what your needs are. I will work with you because everyone deserves dignity at the end of life. So those are your basic differences. Now, how does the doula fit in? You've got hospice, you've got your doctor, your kids are there. Well, I can be your medical liaison. Maybe you want MAID or death with dignity. That's medically chosen suicide, right? I don't want to do this anymore. There are strict guidelines. California is one of the states that allows for it. So as a death doula, maybe your kids are like, I don't want to hear that, Dad. Don't ever tell me that. I don't want to know that. You can tell your doula, and I can go to your medical doctor and say, hey, they're really considering this. Let's get that process started, or let's get a therapist in to talk to them, and let's see where they're really at, right? Companionship. I can be your best friend as your doula. If you don't want your kids to see you in pain, I can be the one to hold you while you're in pain. I can be there to help you with any of your things that you need if you don't have someone there. The doulas started, it really blew up with Suzanne O'Brien in 2017 because of the need with the baby boomer generation. There are so many baby boomers with no children or families that are dying alone that doulas have come in to give that companionship and that autonomy at the end of death. Family support. I just sat with a man with 7 children. Every one of them was fighting right over his deathbed. The last week, they were like, I'm getting his dad. Like, whoa, okay. And grief has many stages. They're not linear. You're in the angry stage. You're in the dial stage. I have no idea what stage you're in from minute to minute. So as the doula, I was able to take each one, sit down with them, find out what their fears and anxieties were, share what the process was, what was coming, what to expect, and how they can be a part of that process. Because hospice isn't going to go, these are ways you can make your loved one feel better. They might, and they'll give you a handout. Here you go. Here's a list of stuff. Good luck, right? Funeral homes, here's a list of stuff. Good luck. I can't really tell you I'm regulated. I can get in trouble. So they call me and go, hey, I got a family that needs this answer and I can't answer it. Can you go meet with them? Absolutely, because as the doula, it's my job to tell you everything. Oh, they want to charge you $10,000 for a casket? Right here in Riverside is a casket warehouse. Let's go get you one for $900. The same casket. Right? So as a doula, I can tell you things that they can't because they're regulated. Legacy support. As legacy, all of us want to find meaning and purpose in our life, right? We all want to know we lived a life worth living, that it wasn't a waste. And as a doula, I can sit with you and help you find what were the things that you felt accomplished. Maybe we do a video collage for your family to keep on when you pass. Or we get all your photos out, and maybe you just want to talk about your lifetime and nobody wants to listen because they've heard it. I'll sit and listen with you. I'll help you build meaning to the end of your life, so when you go, you can go with peace and comfort knowing that you have a purpose. Because everyone has a purpose, whether you think you do or you don't. And the doula's job is to help you find that if you want to. Document preparation. We talked about that Healthcare Advance Directive. I'm also skilled at doing the Healthcare Advance Directive, the Durable Power of Attorney, the Healthcare Power of Attorney, your PULSE form. There's a number of them, so we'll go through those. The doula provides education. Hospice educates so far, but they have so many people and they're so spread thin, right? And especially with the baby boomers coming in, hospices are overwhelmed. They're always looking for volunteers. I've done a lot of volunteer in hospice, and educating people on death is huge. Where do we get death education? They don't teach it in school. They don't teach it at church. You don't get it in the library unless you're looking for it. Where do you go? It's not on PBS afternoons. So there are so many aspects to death and dying that as a generation now, we don't even know or understand because we're so busy going, let them take it over there to that sterile place and deal with it over there, and then we'll all put on our best Sundays and go celebrate their life with some photos. We don't really have funerals anymore. 80% of disposition, I should call it, is cremation. People are moving away from burial as well because the cost is exorbitant. More and more people are being considerate of the earth and what a decaying body does to the earth and the soil. And now there are so many ways for body disposition that as a doula, I can spend that time with you and go through the 900 different things you can do. Yes, you can be a tree. You can be cremated in fire. You can be cremated in water now. You can be turned into compost. You can be turned into a mushroom. You can be made into a stone. My boyfriend wants his voice put on an album with his ashes pressed into it, and I'm gonna have a punk album made for him with his voice in it when he goes. You can have tattoos preserved. There are certain places that will now take and preserve your tattoos. Is that wild? It's amazing. I mean, you can get shot into space. I mean, you know, you can be cryogenically frozen. There are millions of options. How do you choose what's right for you? The funeral home goes, here's your list. Let us know. But they're not allowed to go through it with you. But as a doula, I can. And then the autonomy. In the end, when you can't talk, when your family is fighting, like this guy I just stayed with, his 2 oldest daughters were fighting over what was going to happen. And he had a living will. I was like, hey guys, you don't get to stay. Your dad already wrote it down for you. And Robin, you're the executor. Here you go. Fight's over. It was easy because he was prepared, right? If he hadn't been, some of the families I've been with that are not prepared, then it's a whole ordeal to get the family together and get all of it done at once and be the mediator and try to keep the peace. And yes, I've had to have therapy classes to teach therapy to these people. But, you know, it happened. Oops, went too far. So let's talk about that MAID or dying with dignity, because this is new. In 2016, California approved it. These are all the states that allow for it now. District of Columbia, Illinois, and New Jersey are in danger of it this year. They're trying to get rid of it. There are also a large number of states that are getting ready to bring it on. So it is a growing movement. There is still a lot of controversy around it, but there's enough data now to show that people are using it responsibly and that it's being used appropriately. And there is a process that you have to go through to be approved, but that is something the doula can walk you through that a lot of doctors and a lot of hospice centers will not even discuss with you yet, even though it is a legal option. So, some of the paperwork doulas assist with. Advanced Healthcare Directive, or the DNR, otherwise known as a living will. Your physician's orders for life-sustaining treatment, your POLST. That is your travel companion. Your POLST is filled out, you put it on your fridge, you carry it with you. If you're going on vacation, we got that question, what if I'm not in town? If you have your POLST, that'll have your information. Another option is, the insurance company I work with, they do end-of-life planning for every policy. They hold on to it. If I'm out of state, I call my agent, they just send it right to the hospital I'm in, and they'll have that. Or you can have somebody in your family have it. Okay, hey, call Joe, tell him send over my advance directive, boom. And that's really important. My first father-in-law, I've been married twice. My first father-in-law, when he passed, had a heart attack. We went, we did the work with him. The notary did not show up to the hospital. And we could not find 2 witnesses. We said, well, that's okay, Dad. You're doing great. We're gonna come back for dinner. We're gonna get that done, and we'll be back. By the time we left San Bernardino, got home to Fontana, the phone was ringing, and he had filled it out. He had a DNR. He did not want CPR. Because if you were aware with what CPR does, they don't break your ribs, they're not saving your life. When you come out of CPR, you're in more damage than you are before you have it. But what doctor is gonna tell you that? Your doula will. I'm going to tell you and show you all the things that's going to happen in life-saving, and that's going to help you make your decision on your advance directive, right? But for him, we got there. They had him strapped down fighting him, and his son said, well, he doesn't want that. We're going to unplug him. And they said, well, that's great, but get your 2 sisters here to sign off on that as well. And we had to wait for his sisters to come, and then they had to have their whole thing. And that was like a whole nother day later that he finally got his wish. Now, this was back in 2008. Laws have changed since then, right? The durable power of attorney, like we talked about earlier, that is your power of attorney that allows medical, financial, like everything. I can handle your bills, your bank, I can take care of anything and everything for you. I'm the voice for you when you can't speak. I'm the hands that sign when you can't. There's also a healthcare healthcare power of attorney. You can split that. My dad is in Oregon. My brother is his healthcare power of attorney because he's closest. I'm his durable power of attorney. I handle all of the other big events, right? So that is an option. Guardianship. Do you have children or pets? How many of you guys got pets out here? Do you have a plan for what happens to them when you die? What if you died on the way home today? Does somebody know to go feed your cat and let it out? Or your dog, take it for a walk? That's very important.
Put your parrot in the will. Parrots live 100 years.
Put your parrot in the will. They live 100 years, so do turtles. And spiders live 28 because my tarantula did. So, you know, children and pets. Make sure somebody knows what you want to happen to them. Put that in writing. Last will and testament, any written requests. I know I have my own coffin that lives in my living room. I want to be buried in my coffin. Do not buy one. I have one. Please. I'm also a goth girl, just so you guys know. I'm a morbid goth girl from the 80s. But so these are all really important paperwork to have, and the doula can sit with you and explain them and work them all through with you. Other things they can help you prepare are a list of all your accounts, bank accounts, revolving accounts, mortgages, car notes, credit cards, your stocks and bonds, life insurance, annuities, any of that kind of stuff. They can help you get all that organized and put together. Update and check on all of your beneficiaries, make sure everything's up to date. They can help you with your digital accounts. How many of you have a list of all your passwords in all of your online accounts? Somewhere somebody can find them. Good job, Stephen. I do too, but there's also another thing. What about a legacy account? How many of you have a Facebook or an Instagram or anything? Do you want that to survive when you pass? Or do you want them to shut it down and delete you? Put it in writing. Otherwise you become a memorial account. And you have to dictate who's in charge of your memorial account for Facebook to give them access. Paid apps and subscriptions. What about your Netflix? What about your Hulu? We don't get a bill for that in the mail. That comes through your phone, right? Who's gonna make sure those are shut off for you? As well as all your important paperwork in one place. Birth certificates, deeds to your house and your car, marriage certificates, you know, divorce papers, social security cards, guardianship. All of that should be in one place and easy to find. When my aunt passed, everything was in her computer and nobody knew the password. It took us 3 months to get her life insurance found and paid for, but we weren't keeping her on storage for 3 months. So the family had to do the good old car wash. And we didn't make enough money, right? So, and then, you know, I spent 3 weeks cleaning and tearing apart her house trying to find anything of worth. And eventually I found it, but then, you know, when I needed it, it wasn't available. The Legacy Project, these are things that we can do to help with that. Compiling photos and stories, creating audio or visual testaments, writing memoirs, documenting accomplishments. My father has 2 gold stars from Vietnam. And he is adamant that those gold stars are prominently displayed at his funeral, and they should be. Those are huge awards. He saved lives during battle when he was in danger, and he did it twice. And so he deserves to have that put out there and recognized. That's one of his greatest accomplishments. But I wouldn't have known that if he didn't tell me that. I'm from a traditional Puerto Rican family. My dad does not talk to the girls about those things. That's for the boys, right? And so it took until he got older and I became his executor and his death doula that I learned all of this. So these are ways that your death doula can help. And then how do you fund your exit strategy? How many of you have considered, I know I'm gonna die. I don't wanna talk about it, I don't wanna think about it, but it's inevitable. We are all gonna face that final frontier. Are you financially prepared? You can do life insurance, retirement accounts, annuities, savings, inheritance. Let's talk about making our families do GoFundMes and car washes. We say in life insurance and in doula work, if you love your family, you'll leave it prepared. You'll leave prepared. Because the best thing you can do is not make them make decisions when they're in duress, right? And we do offer free consultations. If you want to talk to us about how do I plan my financial exit strategy, I got 2 people with me right now, Felipe and Shannon. Stand up, you two. These guys are experts. They've been at it almost 20 years. So you got questions, they'll help you. They've seen every scenario. Shannon, do you want to take a minute and talk about the importance of having finances in place? Thank you. This is Shannon.
She has said a lot of the truths about living. We eventually won't, right? And when we have our loved ones, or even if we're by ourselves, there's always a plan. Planning brings peace of mind, right? When you're going to drive across the country, if we're leaving here in LA and we're driving to New York, are you gonna wing it and expect to get there in 3 days? No. If you want to get there, you know where you, and you know exactly what time you need to be there by, you're going to pull out the GPS, and you're going to pull up the map, and you're going to plan your trip, and you're going to figure out, I'm stopping in Tulsa for the first night, right? Unfortunately, we know death is coming. We may not know when it's coming, but we can plan along the way for getting there. So, yes, I'll get there. So the biggest thing that we have found is that a lot of people think that life insurance and annuities and a couple of the other tools, the savings tools that we use in the financial services industry are not available for one reason or another. I am here to tell you that is not the case. That even things like HIV and AIDS and cancer and different things like that, I have carriers on my platform that I work with, that we can work to see what kind of coverage can be offered for you in your particular customized plan. The answer is no longer a absolutely not. The answer actually now is you've got options. Options mean good things. It means you guys can have a plan. It means you can actually have hope and not be alone and not wonder about what is the cheapest way to do anything. You can go with dignity because you have a plan and a way to fund that plan. Some of the beautiful tools we use, which she wanted me to share with you, some of the tools we use, it doesn't work for everyone, but some of the best tools we have are actually tax shelters. That when you're saving for an event in the future, it does not discount and go against your Medicaid and Medicare qualifications. If we can put you in a plan like that, that's a win-win for us. You get to save, you get to have a plan, and you have the tax advantages that in some cases we can make that happen. That's always one of our goals, is how many bells and whistles can we get you for your customized plan? Because we want to give you all the options that are possible, and there are a lot more than there was even 15 years ago. So I'm excited to be able to say that we can serve even this community with its challenges. There are more options there than there have ever been before. And I'm excited to be able to say we want to help you, we can help you, and we do this complimentary. We do not charge for our consulting. So you do not have to waste money, just a little bit of time for us to figure out who you are, what your needs are, and where we can best serve you.
Thank you, Shannon.
I thought that was really important, so that's why I kind of asked her to come up and bring that up, especially the tax shelter part. My parents are on Medicare or Medicaid. One's Medicare, one's Medicaid, and their stuff is in an annuity so that they can continue to get money throughout the month and not be short on funds, but still qualify for their services. So some of the information you need at the time of death, the doula can help you with as well. What funeral home you're going to go to, because that's the first question they're going to ask. Where do you want us to send them now that they're dead? We're not keeping them at the hospital. If it goes to the coroner, that's cool, but when the coroner's done, he's still going to send you to a funeral home. Do you want cremation or do you want burial? What do you want? Because you can do direct cremation, which takes you straight to the crematory. You skip the funeral home, saves you a lot of money. 3 weeks later, you come home, and then you can schedule your service whenever. How do you want disposition of your body? Again, we covered that: cremation, burial, composting, space dust, album, stone, whatever works for you. Are you an organ donor? Discuss what that means. You don't get to choose where you go. They pick you up and take you where they want you. You can ask, hey, I want to go to the body farm, but they might just put you at Chaffey College in the cadaver lab. You don't get a choice, and you're not always approved. My father has Agent Orange poisoning. He wanted to donate to science. They laughed at him and said, no way, you're going in a steel container on a military base when you go. Because he's part of their research and he's got it bad, right? What type of service you want? Some people say, I don't want anything at all. Well, you're dead. So you don't matter. I'm just gonna say it because nobody else is gonna say that to you. The funeral is super important. That is how you validate the life you lived. The people who love you get a chance to say goodbye, and it gives closure to the legacy that you've left. Don't cheat the people who love you by saying, don't do anything. Say, hey, you choose what you want to do. I don't care. Or I want a funeral. I'm Catholic. Hey, we do 3 whole days. I get to see the family for 3 full days. And then, your obituary and announcement. Obituaries are like $600. You don't have to have an obituary, but they're not going to tell you that at the funeral home. They want your $600, and that goes to the newspaper. But you can do an announcement. There are hundreds of sites you can put memorial announcements on. There's a death registry for every county, all those things. So those are some things you'll need at the time of death, but the most beautiful thing about a doula is the after-death care. The funeral home, when you're dead, they're like, you're done, that's it, we're good, okay, on to the next funeral. The hospice goes, there's no need for us anymore, we're picking up all your equipment. Now the chaplain will come and they'll help you with grief counseling, and that's great. But who's gonna be there to help you make calls to your loved ones, help with your funeral arrangements, close your accounts, handle your personal effects, help you clean up that medical equipment, and give you extra grief support? I have a friend, she goes twice a week to a grief support. She still can't get out of bed since her husband died. I go twice a week and I help her get out of bed and get a shower and take her out of the house just to get her back into the living. She caretook for 4 years and she gave all of herself up in that. So these are really the benefit of having a death doula, is that after death care. Because after that, funeral home, where do I go? What do I do? How do I close this account? Here's a list. Good luck. Because they're not allowed to. It's not that they don't want to, they can't. And, making calls to loved ones. When you put your list of accounts and everything all together, put a list of who to call. And start with the furthest person away. No one thinks of that. Hey, well, I called Cindy. She's down the street. But then I'm going to call Bobby in 3 hours, and he's 5 hours away. No, call Bobby first. Cindy's down the street, right? So having that kind of knowledge of which way to go and what kind of logistics makes a big difference. And then, how do we get paid? Oops. It's all private pay. Everything for doulas is private pay right now. Savings account, cashed in stocks and bonds, retirements, annuities, life insurance. I am working, because we work with so many insurance companies, we are working with them to create an insurance policy that will cover doula services. I am pushing for that really hard, because I'm just trying to knock everything over, because I think it's important. And then, what's the cost of a doula? Anywhere from $25 to $300 an hour. Some packages start at $1,500. That includes like 4 hours a day for 3 weeks, plus maid care, plus respite care. So it depends on the doula and who you work with. But since it's not regulated, pricing is everywhere. It just depends. I like the sliding scale personally. I think that's more important. Where to find a doula? Doula Givers, created by Suzanne O'Brien, who does free doula training online. If you have someone and you want to go to Doula Givers. You can sign up for all of her free doula and end-of-life care training. INELDA, International End-of-Life Doula Association, and the NEDA Alliance. So all of those guys, they're all great, and they all have doula registries. You can also just search death doula near me. Any death doulas that I found, you guys have a bunch here in Palm Springs, there's some in Orange County, there's a bunch in LA, there's none in the Inland Empire. So I'm working on that, I'm training some doulas out there. But that's how you find a doula, or ask around. Hospice can connect you, and doctors. So, questions. I got 10 minutes. Who wants questions? Hold on, our mic guys are running. There we go. Thanks. Are you on?
I don't know. Maybe I should use my outside voice.
Yeah, because we got big voices. Go ahead, Ted.
So I'm said cousin from the beginning. So
I just want to shout Marjani out. She's amazing. And saying that when my mom passed, I would not have been able to do it without Marjani's help. And so she was not my doula because I was not the person that was dying, but she was my doula because I could not have gone through the process without her. And so that's something else that you can consider. The things that she's talking about, sitting with someone, helping you clean, coming to help you pack up clothing after your loved one is gone. All of those things are tremendous emotional drains, and so having a death doula to be able to support you in those things is invaluable. And so I'm biased towards this particular death doula. However, find someone, the benefits far outweigh any cost, any drain, any effort. It is worth it to have someone in your corner.
Thank you, Bridget. Is that a question in the back? Oh, good. I was waiting for you to jump in, my friend.
Because she told me to.
I did.
Oh, turn it on. Keep pushing the button back.
Now, okay, sorry about that. So thank you for this. I mean, I think a lot of us, you know, we're a little bit older and lived through AIDS. You know, we were all doing this stuff, right, for each other back in the day. So it's really great to see this as kind of formalized, approved. And there are people like you and hope. Is there a licensing process for what you do?
There is. There are several different doula schools. Not all schools are the same. They range anywhere from $250 to $1,700. But the ones that are more expensive give you some medical experience as well, even though you're not trained in medical and you're not there for medical. Suzanne O'Brien is an RN. And so she gives a lot of medical information to help you be aware of, like, if it's this type of illness, watch for this. If it's this type of illness, watch for this. This is how you move them for bed sores, how often you should move them. So that's a more expensive training. Some of the less expensive focus on the spiritual and companionship level. So they don't get into the medical. But there are certifications. You're not required to have one because it's not regulated right now.
Right. Okay. Then my other question is, thank you again for talking about medical aided dying. A lot of people don't really understand how that law works. There's limitations. You can't say if you have ALS, it's like when I can no longer talk, that's when I want you to pull the plug. Doesn't work in situations like that. So could you walk us through kind of what the requirements are and how that works?
Yes, great question. So in California, the requirements for MAID, and it's called MAID in California, that's medically assisted individual death, okay? You have to be under the care of 2 separate physicians. You have to see a therapist for at least 3 sessions of an hour and a half each. You have to be terminal within 6 months of death. And you have to be losing faculty. So if they're all in agreement and they can approve it, it is a bit of a process, but once they approve it, you're given a pill. They are not allowed to administer for you. That is the thing. Everyone goes, oh, I'm getting euthanized. And I'm like, that is not a word we use for humans. Okay? Euthanasia is when someone else gives you that medication. Medical aid in dying or individual dying or death with dignity, they both have websites and they're .orgs, but you just type in death with dignity or MAID or medical assisted individual death. They will tell you that you have to be fully mentally capable and you have to be physically able to administer the medication to yourself. So you choose when, where, and how you're gonna do it, but they help facilitate that. And as a death doula, we go a step further and help you plan when you're gonna do it, what the situation is. I have a friend, she had breast cancer. She used MAID about 4 years ago. And she came to me and said, you're my doula, my husband's still in denial that I'm gonna be dead in 3 days. And I went, okay, that's fair, I understand. As a doula, I'm not just the dying's doula, I'm the family's doula. And so I sat with the husband, helped him come to a little more terms because it was hard for her. She wasn't letting go because he wasn't letting go, right? And so she was a witch, she wanted all her friends to come decorate her cremation burial container. So I went and I got it and I brought it to her house and we decorated it. We did ritual and we sang songs and we danced around her and we put her in her cremation container while she was alive. She wanted to experience it. That was her good death, right? And in the end, she wanted us all to have a moment with her privately, and we all did. And in the end, I was the last one, and then I held her glass of water while she took her pill, and then she took her water from me, and I held her hand and called her husband in, and together we sat with her until she took her final breath. And that was her beautiful death. And everyone thinks a beautiful death is, oh, it's gonna be quiet and serene, come in, shh, they're dying. Right? They're already dying. I had a lady that I sat with. She was a 49ers fan. She wanted to go during a 49ers game. She went after a touchdown. The entire house was in her room watching a 49ers game, and they hit a touchdown. Her son jumped up and did this and turned around, and she went, ah. And it was done. But that was her beautiful death. I've been a goth club girl since I was 18. I'm 50 years old. I've started clubs all over the United States that are still going. I told my mom when I go, stand me up on the dance floor. And get everybody out there and rock it out hardcore until it's time to bury me. And they do have living wakes now too, where you can have a wake if you're terminal while you're still alive. And they'll bring you into the funeral home and let everyone come in and do your whole service while you're there. And they can say all the things they want to say. Some people choose to lay on a bed and be like they're stoic. Others sit on a throne. So, you know, there's all these options now. And death is becoming more commonplace because of COVID, right? COVID brought it to the forefront for a lot of people. I sat with one member of a family, and within 2 weeks, all 9 members were gone. From 6 years old to 96 years old. And I sat with each one of them because of COVID. And that was rough. But boy, did my kids be like, man, death is real. Yeah, what do you think I'm doing all the time, guys? Why do you think I'm gone for days at a time? Right? But it's also that thing, nobody wants to talk about it. We plan vacations, we plan births. Questions? Mike? I love technology. This whole week, technology has aided me, though.
Since you mentioned talking about death, the PALS planning ahead for Western Day seniors here in the desert, we have once a month online, the first Thursday of every month, online death cafe. And a lot of people show up and they don't know what to think about their death or how to sort this out. And this is a place where they can say something that's a little off the wall and no one's going to get on them about it. But then they could hear what that sounds like and then figure it out for themselves what they really want. So I just wanted to encourage folks to check us out, that we're out in the hall and we have, we can sign up for the Death Cafe.
I think that's awesome. I host Death Cafes also. I have one coming up April 19th in Crestline. And then I'm going to do a Death and Donuts, because Death Cafes can't have speakers. So I'm going to do Death and Donuts. I'm coining that one so I can be a speaker. Go ahead, Felipe.
So I was going to say this to piggyback off of what Marjani has been talking about, Shannon as well. No one plans to fail. But when you fail to plan, that's what ends up happening. And the thing is, when we don't create a plan ahead of time, all of these things that we're talking about today, someone else is going to make a plan for you. And odds are it's not going to be the plan that you wanted to have for you. It could be a relative, and if it isn't your relative, because I know you were talking about that, they kind of look, you know, who's your blood relative, who's you know, and if they don't find anyone, guess what? The government's the one that's going to make a plan. And that's where things get dicey. And so all of a sudden you realize, hey, you know what? This is why these conversations are so important to have them now, so that we can start creating, formulating who are those partnerships that we're going to create with, whether it's with this group or that group or these conversations. It's online. It's, you know, people that we get to know and trust, and now be able to continue that conversation on to. So for that, thank you.
Thank you, Felipe. So that wraps my time. I just want to say thank you so much for having me. Oh, one more question? All right. Over there.
You mentioned the deep sleep. Is that a California thing?
So the palliative care, she asked the deep sleep, so sedation to death, right? Is that a California thing? That is a federal thing. So palliative care is federal law now. California does have its own laws, but palliative care, what I was discussing, those laws that I mentioned are all federal laws. So palliative care, there are some strict guidelines to getting sedation till death. But if it is something you're interested in, discuss it with your caretaker or your health provider or your death doula, and then they can go through for your particular situation. Because different scenarios, if it's liver failure, if it's ALS, so different things dictate what those procedures are. But I'm out in the hallway. I have some flyers and some business cards. I'm happy to talk to anybody who has questions. I also do a free 30-minute consultation about death planning. And then we also do the free financial consultation. So thank you so much, you guys. Have a great day.
The liveliest discussion of death I've ever seen. So now, we move on to the next PowerPoint. And our next speaker is actually a dialogue with you. Medical plan review and what your insurance agent can do for you. Cesar Perez is a native of the Coachella Valley, where he still resides alongside his wife and 4 children. Started his journey in Medicare health insurance back in 2012 and formed Cesar and Associates. And the mission of his company is to simplify access to healthcare and Medicare beneficiaries, as well as the general population. The motto is, to guide, offer and protect our policyholders, one policy, one person, one community at a time. In doing so, he has met quality people like Bill Hart's Desert Insurance, whom he has decided to partner with to accomplish this goal. Please welcome Cesar Perez.
Wonderful introduction. Thank you, everybody. Well, today, and by the way, I love the name of this conference, Self-Advocacy in Healthcare. So hopefully we'll give you some pointers so that you can self-advocate, but also serve as a resource. And again, my name is Cesar Perez in partnership with Bill Hart's Desert Insurance Agency. That is Brian. I believe a couple of you recognize Brian, right? Well, Dr. Adams, how are you? Hi. Anywho, so we have a Heart for Medicare. The first thing that we usually like to talk about is, well, number one, we can't say we work for the government, so, but we are local. One of the things is we are not affiliated with Social Security or Medicare. Anybody that calls you on the phone and says that they're from Medicare or Social Security, just be careful. There's a lot of scams going on, especially when you're turning 65. You all of a sudden become very popular, right? Start getting a lot of mail, start getting a lot of phone calls. Nowadays it's non-stop text messaging. Even I get the text messages, and you know, I'm nowhere near 65 yet. So yeah, anywho, so just be careful with that. We are licensed by the California Department of Insurance to be able to provide this information to you, and then we are certified by each and every one of the health plans that we represent. Now, our main focus is to educate Medicare eligible beneficiaries about their plan options. And one of the things that I do like to always bring up is not only do we sit down with somebody and simplify the access to healthcare in terms of making it simple for you to understand the health plan options, but that's where our relationship with you begins. What I mean by that is, for example, in our case, we have an office down in Indio. So anytime that we onboard somebody, I always tell them, hey, we work for you, not only me, but my office works for you. So anybody up front, any of the girls, if you ever give us a call, usually we like to resolve and be a resource to you in terms of service. What do I mean by that? Well, a lot of times you might have a problem, an issue, maybe a referral's not going through, maybe you got a bill. A lot of times what people end up doing is they call the insurance carrier directly, and they might reroute you to the Philippines or, you know, God knows where. You hear chickens in the background, and so then you're in there 3 hours later trying to get the issue resolved, and they might be bouncing you back and forth like a ping pong ball. And, you know, needless to say, if your hair hasn't fallen off by then, you're, you know, trying to, you know, do that. So I always let our clients know, hey, you know, make us first phone call, or if you forget to call us first, know that you're able to reach out to us, and usually we know a little bit better what you're trying to accomplish, so then we can either guide you or we can help you with it. So that's something big that we pride ourselves in. We just don't like, hey, let me, you know, help you sign up and then that's it. No, we actually stick around, and we're there as a resource in the event that you were to need us to help you and guide you through any of those processes. For example, you know, we do a lot with formulary. Formulary is the list of drugs that the companies cover. So that's one of the biggest pieces of the puzzle when it comes to picking a plan, because everybody takes different medications and all the plans cover those medications slightly differently. So that's gonna be one of the things that also can change, right? So like all of a sudden your doctor prescribed a new medication. Well, you go to the pharmacy, hey, it's not covered. Well, what do? You can go back to the doctor, or you can call the office and we can say, oh, you know what? Ask your doctor about these specific ones, because these are the ones on your formulary. And if you don't, and if none of those work, let us know, and then we can, you know, help you with what's next in the process. And, you know, instead of spending 3, 4, 5 hours on the phone, you limit it to one phone call, and, you know, you got your answer, or a better answer than you would have otherwise. Best part about all of this is when we help somebody, we do this at no cost. The reason we can do that is because we are compensated by the health plans And so the good thing is we are compensated the same, so there's no incentive to say, hey, go to this plan or that plan. Our incentive is really making sure that the person's taken care of. And yes, there are going to be some plans that might be a better fit than others, and there are going to be some plans that are definitely advocate better for members than others as well. So I just thought I'd mention that.
And if you
Yes.
already have a plan,
Mm-hmm.
we can still call you if we're having a problem?
No, because unless we signed you up, right? Normally you should call your broker, right? Whoever helped you sign up on the plan, they should be able to help you. If they're,
Well, I have
yeah.
HealthNet and they're awful.
Oh. Well, you can call us, and there might be something that we can do, especially, a lot of times might be plans that are better fits. We still like to give you like tips, like, hey, do this or try that, and it might be helpful. So, I mean, it never hurts to call. We don't discriminate. So we'll try to help you as much as we can. Okay, and then I'm gonna talk a little bit about, for those of us that are under 65, there is, here in California, we have Covered California. There are some laws that changed with Covered California as well as with Medicaid, Medi-Cal. So I'll talk a little bit about that, just because, not everybody is 65. So yes, about 2 million Californians use Covered California, and there's over 11 different companies. There were some companies that went away, and unfortunately, they weren't able to, I guess, function, and so they just exited the market. And then a lot of what happened this year specifically was the premiums went up in price because they were unable to come to an agreement in Congress, and so we were waiting to see what happened. At the end of the day, nothing passed. Some of the law that was supposed to be passed was going to bring on some additional monies towards subsidies, which the consumer would have received. But because that didn't go through, many people saw their premiums or their portion of what they paid for on a monthly basis go up substantially. So, I've had clients that went from paying like $150 a month to like $400 a month. So at that point, it becomes a question of, well, do I want to eat or do I want health insurance, right? And that's a tough decision. So we did see many Californians just opt out of coverage because of that, right? So, as a result, I guess we took a step in the wrong direction. We'll see what happens here in the next year, but because of not passing that bill, it was detrimental to Californians as well as to other people in other states. And then when it comes to Covered California, there's different levels of coverage. So not only were subsidies reduced, but if you see, it says minimum coverage, and then there's bronze, silver, gold, and platinum, and then in silver there's different levels. It says silver 73, 87, and 94. So under Covered California, a person can get a subsidy, but they can also get what we call an enhanced silver plan. What that means is that if you fall under a certain level of income, and there's ranges to this, you can also receive not only a subsidy, but also an enhanced plan. So for example, the enhanced silver 94 plan is the equivalent or even better coverage than the platinum plan. And it's at the price of the silver plan for that person if they fall in that and in the level of coverage for the percentage of above the poverty limit. And then it goes to silver 87, silver 73, and then the regular silver covers 70%, and that's based on an actuarial number. But platinum's 90, gold is 80, silver 70, bronze 60, but then you have the silver 73, 87, and 94. And so it just depends on what you qualify for. But this is essentially the grid that Covered California used, and they all have different co-payments depending on the plan that you choose. You don't have to memorize any of that. I just thought I'd show it to you. It is pretty complex, but when you sit down with us, we essentially narrow it down based on doctors and what you're trying to accomplish with your healthcare. that is what Covered California looks like. Now,
Great question.
oh, sorry, go ahead.
So is this thing on?
Yes.
Okay. So, what's the limit of income for subsidy? In other words, if you're at poverty level or a double poverty level, you can get a subsidy. But if you're beyond that, you get shit.
If you're under, yeah, unfortunately,
And
it's
so, what
about
is
400.
poverty level, and what is double poverty level?
So it's based on the household, the size of household. So individual, right? So if it's one person, it'll say like if you're below 138%, so it's about 23,000. If you're below $23,000 for one person, then you go to Medi-Cal, you pay no premiums. If you're above that, and then up until it's like 28,000, then you fall in this range where you qualify for like a silver 94.
If you're a working poor person, and you live in Palm Springs, and you make subsistence wages, you cannot afford insurance and rent and food. And no, if you're a working, I mean, there's these people that are in between, and I'm one of them. There is no assistance for insurance. The premiums cost more than my rent. I could lease a new Porsche, and that's what insurance would cost. And there isn't a safety net for the people in between. You either have to be dirt poor, but if you're a working person in a barely subsistence income in this expensive town, you don't carry insurance.
So where do you go?
So you go to the corner of Ramon and Sunrise, and you go to Riverside University Health System, and you pay out of pocket for every single thing you have done, and they're reasonable, and they're keeping me alive. But the Covered California, big fail, and federal government, big fail. Yeah, well, we knew that. But I just wanted, we're talking about the little sliver of people that are going to be able to get insurance through Covered California and be able to pay rent and be able to eat. It's a very small, and it's going to be a smaller figure because of the tax credits that were not moved forward. We're going to see millions off of insurance. What do we do then?
Yes, I agree with you. Yeah, we saw a lot of people have to decide what, like you said, whether I pay groceries or I get coverage. And yeah, we did see a reduction of about 30% of people thus far might be might get worse.
People,
yeah,
right?
Might get worse here in the coming years. So unfortunately, like you said, yeah, it's something's gotta give. But a great tip on going to university health systems if they can be.
Well, they're going to get busy.
Resource, yeah.
They already.
I bet. Anywho, so yeah, again, like you mentioned, premium tax credits, they usually lower the monthly cost of insurance, but then because it's going up every single year, and then the tax credits got lowered, it leaves a larger gap, which means you pay for that gap if you are on one of these plans. So that's exactly what you're talking about when if you're making a subsistent wage, the fact that you saw that go up, that has something to do with it. And again, the subsidies are supposed to be available for people between 138% up to 400% above the federal poverty level. And supposedly the rule is you can't be spending more than 8% of your income in health insurance. Right? And yeah, there's different metal tiers like we discussed, but again, that's Covered California. When it comes to Medi-Cal, some of the changes there. So California had done away with the asset limit, but then it has come back for this year. So the asset limit is $130,000 again. It used to, again, it had gone away, it came back. Now, it's specifically for people with disabilities and seniors. And for everyone else, really, it's called Magi Medi-Cal. So if you're under the age of 65, and to qualify for like Medi-Cal, as long as you're making under a certain amount per month, they don't look at your assets typically, and you can qualify for Medi-Cal. Yes, Steve.
So what are included in assets? Like I seem to understand like your car is not included as an asset base.
So usually, thank you for the question. Usually under the assets, they won't look at, you can own one property and one vehicle, but then anything above that, they count it into that asset limit. They will ask if you own mineral rights, oil rights, stocks, bonds, IRAs, retirement accounts, bank accounts, jewelry, cash, all of that is gonna fall into assets. But you can't own, I've seen people be on like Medi-Cal and they might live in a $1 million home, but it's one property, so that's not counted, so that's exempt. But when we're talking about assets, it's beyond that first home and first vehicle, then everything else gets counted. And you're supposed to self-attest, so you get like a questionnaire, and they ask you, you have this, and this, and that's how they base it off of that. They'll ask for proof, so if you have another vehicle, they'll ask for the registration, just to see, hey, how much is this vehicle worth, etc., so on and so forth. Yeah, like I mentioned, there's income verifications. Oh, appreciate it, thank you. Income verifications through Covered California. Usually you will also send them, like either if you're working, a pay stub, or anything like from Social Security, if you're getting income from disability, or wherever the income comes from, you're supposed to send them proof. Give me a second.
While Cesar has a drink, I just want to say, if you have health insurance, I'm single and looking for a husband.
Stand up, just stand up.
And if you have mineral rights, I'm very available. Mineral rights.
Those gas leases.
Yes, those gas leases.
And so next topic I'm going to cover is Medicare. So anybody 65 or over, and if you do have a disability, usually you're going to be on the Medicare program. You must be 65 again, and must be at least a legal resident for 5 years. And normally you get a red, white, and blue card, a Medicare card. It used to have your Social Security number on there if you were on Medicare prior to 2019. They finally got smart enough to realize that that might not be a good idea, so they removed those numbers. Now it's just a series of numbers and letters. And usually you have Part A and Part B. Part A covers skilled nursing facilities, hospice, and hospital care. Part B covers outpatient procedures like doctor visits, x-rays, lab work. All of that's under Part B. And then you have Part D. D is for drugs. Now, back in the day, it used to be a lot more confusing. It's been simplified. So usually under Part D, you may have a deductible. Some plans have a deductible, some plans don't. The deductible that they can have is up to $615. And there is what we call an initial coverage limit. The initial coverage limit is the amount that you're gonna pay out of your pocket. And usually you pay either a co-insurance amount or co-payments. And if whatever you pay reaches that initial coverage limit, which is only $2,100 in the year, then you pay zero because you go into catastrophic, and then your co-payments and co-insurance go to zero. And that's now a lot more simple than it was before. So now just think about it this way: once you reach $2,100 out of your pocket, then if the medication is on the formulary, then you pay nothing beyond that. Yeah. Wait for the mic too.
Okay, so I have not had to pay, I guess, my ADAP, because my HIV meds are like $3,600.
Right.
ADAP set up, I think.
Yes.
$721.
Yes, so there's programs like, for example, ADAP that will help you pay for prescriptions. There's ADAP, and then there's LIS. LIS is a federal program, so then if you qualify for any of those programs, then that could offset the cost, obviously. So yeah, in your case, you don't have to reach that $2,100 in the year. So that's a good thing.
But what is that top one? Go back one. I don't
Yes.
understand annual
Deductible, yes. So first you must, so if, let's say your plan has a deductible, so he was asking about the deductible. If your plan has a deductible, usually you're gonna pay 100% of the cost of the medications until you reach the deductible. Once you satisfy that deductible, you're gonna pay either a co-insurance or a co-payment. So let's just hypothetically say that you're taking a medication and the cost of it is $100. If you are in your deductible stage, you're gonna pay $100 until you reach the 615. Once you reach the 615, let's just say you have a 25% co-insurance, so instead of 100, you would pay $25 for that medication. And then if during the calendar year you end up spending $2,100, then it will go to zero. So does that make a little bit more sense?
Well, I understand the initial coverage, but I don't get that first one. I mean, I'm really familiar with the initial coverage. But
You might not have a deductible on your particular plan, so that might be, but if you do have a deductible, you're essentially paying 100% of whatever the medication costs until you reach that deductible. Then it goes down to whether it's a percentage in your initial coverage limit or it might be a co-payment. So it just depends on your plan.
Yeah, well, I'm on an HMO.
Right, so yeah, you might not even have a deductible. So once you're on Medicare, you essentially have a couple of options. So that red, white, and blue card is the Medicare card. That's how it looks. Now, on the left-hand side, you can either keep Medicare as your primary. You can keep Medicare as your primary. If you do that, you're able to go to any physician that accepts Medicare, and you can add a supplemental plan, also known as a Medigap plan, which normally if you're on a Medigap or a supplemental plan, you're paying a monthly premium, and it works in conjunction with Medicare. So usually supplemental plans are gonna cover anything and everything as long as it's Medicare approved, and the amount that they cover depends on the plan that you have. So the more it covers, the more you pay usually out of pocket for your premium. And then you usually you have to add a Part D plan to that. The Part D is for the drugs. So then you have 3 different cards and 3 different payments, because Part B of Medicare you must pay a monthly premium for, then the supplement, and then the Part D. Yes, Steve?
So I have 2 questions.
Yes.
One is, Medigap can cover, like if you bought an AARP supplemental insurance, is that one of the examples of supplemental insurance?
Right, yeah, there's many companies that will offer Medigap plans, and some of them will offer both Medigap and Part C or Medicare Advantage, which I'm gonna talk about next. So that kind of gets confusing because they might offer both versions, right? But yes, one of those would be AARP, United Healthcare would be one of the companies that offers a Medigap or a supplemental plan, yes.
So my other question is, doesn't ADAP cover your supplemental, or am I incorrect?
Yes, so if you are eligible for ADAP and you are not eligible for Medi-Cal, they can pay the premiums for a Medicare supplement. So that is something that you may want to bring up with your counselor if you're, if you lose Medi-Cal specifically, and you want to make sure you keep all your same doctors. Usually if you add a Medicare supplemental plan, and as long as the doctors accept Medicare, you're going to be able to keep going to those doctors. And obviously you have to add a Part D for the medication portion of the coverage. The other option is a Medicare Advantage plan, also known as Part C. Now, if we think about it, Part C combines Parts A, B, and D. So it's like a bundle. Now, under Part C, most of the plans under Part C are HMO plans. So you will typically belong to a medical group, and you have a primary care physician, and that you go to that primary care physician, and they will refer you to the specialist. Now, many of the Part C plans give you additional benefits. For example, you might get like a gym membership, you might get vision, dental, acupuncture, chiropractor. All of those additional goodies and perks come typically with a Medicare Advantage plan, and there are generally many different companies, and again, some of these companies also offer Medicare supplement plans. That's why sometimes it's a little confusing to grasp, because when somebody says, hey, I have a supplement with United Healthcare, well, they might have a supplement or they might have a Medicare Advantage HMO plan, we don't know, but you know, people call it, oh, it's my supplement, right? So it gets confusing because of that sometimes. Just to understand, I mean, since we do it every day, we're pretty familiar with this. And so these are some of the companies in Riverside County, and you know, we have Scan, or over here with Matt, part of Scan. And actually, that's one of where we just wanted to give you guys an example. So like Scan has different plans. One of the plans is the classic plan, and like this is what it looks like. So if you had Scan Classic, your premium is $0, and then there's a maximum out of pocket, which is $399, which is one of the lowest ones for any of the plans. Hospitalization $0, procedures at the hospital up to $50, and then primary specialist $0, emergency room $90, waived if admitted. They even give you worldwide coverage. So like if you are traveling and you have an emergency, they can reimburse you. If that's the case, you bring your receipts and they'll reimburse you. Urgent care $0, radiology, MRIs, all of that $0. And so you can see that the benefits are pretty rich. If I go on to the next section, these are like the additional benefits that they offer. So like when you're a Scan member under the classic plan, they'll give you a dental plan. It says preventive and comprehensive, so they have a dental HMO option. And then if you want the dental PPO, usually you pay an additional amount, and it'll give you a PPO policy under Delta Dental. Vision, they use IMED, and they give you a $300 allowance every year under this plan. For hearing, they even offer hearing aids, so you can get different models, usually 2 different models, at either $550 per hearing aid or $850 per hearing aid, and you're able to get 2 aids per year, and that's an additional perk that you get just for being on that plan. Transportation, 36 one-way trips, so they won't take you to the casino, but they'll take you to the doctor, specialist, or the pharmacy. And even some of the plans will even take you to other places like the senior centers, or even to get groceries. Gym membership, they have gym membership available. Over the counter, usually they'll send you this nice MasterCard, and they'll give you, it's $150 every quarter, so you can purchase over the counters like vitamins and things of that nature. And it does, it doesn't roll over, but if you don't use it, you typically lose it. Chiropractor, acupuncture, they're one of the plans that give you routine chiropractor acupuncture. That just means that you do not need a referral, and they'll typically give you 30 visits per year. You can mix and match or do one or the other, and they have a 4 out of 5 star rating with Medicare. So that was an example of a Medicare Advantage plan. These are the Medicare supplement plans, and I'm not gonna, go through every single one of them, but for example, if there's a plan that's, if you see A, B, C, D, F, G, so if you look at F and G, those are the plans that cover the most. Anybody who was eligible for Medicare prior to 2020 is able to get Plan F. Anybody eligible after 2020 can no longer get Plan F. They can only get Plan G. These are the plans that cover the most. And for example, Plan F checks all the boxes, if you can see. So like hypothetically, let's say you had Medicare and supplemental Plan F, you really don't have to pay anything out of pocket as long as it's a Medicare approved service. You just show your cards at the doctor's office or at the hospital, and all the billing's taken care of, as long as you're paying your monthly premium. With Plan G, the only difference between G and F is the Part B deductible. So for example, For 2026, the deductible for Part B is $283. So that just means that if out of your pocket, once you reach the 283, after that everything is covered at 100% as long as it's a Medicare approved service. And usually under supplemental plans, you also have a foreign travel coverage for emergencies, and the plan will pay up to 80% for an emergency. Now, things to consider when you are choosing a plan, a Medicare plan, whether it's gonna be a supplement or an Advantage plan. When somebody sits down with us, we really take a look at the whole picture, and we'll explain everything, break it down and say, hey, well, these are the options, which one seems better? Well, this is better for me, or this is better for me based on my situation. Maybe I have a doctor here, and then I have a doctor in LA, and then I want to go to City of Hope. So then based on that information, we say, well, it might be better for you to go this route. Now, again, we take into account doctors, but we also take into account medications. Everyone has different medications, so not all companies cover all medications. So then when we look at that, we plug those medications in, and we know which plan is gonna cover those medications at the lowest cost, and they'll have them on their formulary. Again, if other benefits like vision, dental, hearing, transportation, if those are important, absolutely, we wanna make sure we take those into account. And then there are specific plans for people that have chronic conditions. Typically the chronic conditions that are eligible here in Riverside County for certain, we call those dual chronic special needs plans, are gonna be like heart conditions or diabetes, mental health conditions, and also, I'm sorry?
What about HIV?
No, there's not a plan that caters to people with HIV specifically, but one of the other conditions is like COPD, and they come up with those plans because they will usually give you additional perks. Like for example, a plan that's for people with diabetes might include better coverage for insulin, right? Somebody that has COPD, maybe the inhalers, they got the inhalers on the formulary. So that's how they come up with those plans. And then obviously if you have any changes, or if there's gonna be changes in the coming years, whether it be you're moving, or maybe you have an income change, or whatever the case might be, then we take into consideration all of those scenarios. Now, again, if there's any questions after this, we're out there, we'll be here for a while. We're always happy to be a resource. We're always happy to help. Some of the other items that you want to consider are, if you're still working, let's say that you don't plan to retire, you have employer coverage, well, hey, you might end up waiting until you stop working if your employer coverage is good. And usually we'll determine that based on, because sometimes employer coverage is not great, right? The co-pays might be higher than if you were gonna be on Medicare. Maybe you're having to pay for your employer plan. Sometimes people pay for it, sometimes it's covered 100% by the company. So all of those are gonna have an effect on your decision. And then if you are eligible for Medi-Cal as well, so like there's people that have dual coverage, they have both Medicare and Medi-Cal. That's also very important. And again, if you are retiring soon and you are gonna lose the benefits, you wanna make sure that you start doing some research with enough time. You don't wanna wait till the last minute and do it, at the end of the end of the month, basically. Perfect. Now we can open it up for questions. If there's any questions, we'll be happy to answer them. Or if somebody has a more specific scenario, come outside, we're there, and we can get in touch with you, and obviously make sure that we point you in the right direction. Got a question?
Yeah, on that next to last slide, the understanding Medicare, we're calling something about Medicare Part B, needing to sign up for that right away after 65. I'm not sure how that fits in.
So, yes, so when you are, before you turn 65, you want to make sure you sign up for Medicare, and you want to usually sign up for both unless you're getting coverage from your employer. Then you can waive Part B, because typically Part A, there's no premium to it. You don't pay anything for it as long as you have the credits, which are 40 quarters. But for Part B, everybody has a premium. So sometimes, let's say you're turning 65 soon, if you have employer coverage and the employer coverage is as good or better than Medicare, then you may hold off on signing up for Part B, so you don't have to pay that premium every month. But let's say that maybe it's not better than what you could get on Medicare, then you could sign up for it and waive your employer coverage and be on Medicare if it's better for you. So it just depends. But yes, you can either wait if you're still going to be working and having employer coverage, or you can activate it when you're 65. The important thing is that, let's just say you did waive it. When you're going to retire, you want to make sure you get the proper forms so that they know that you had other coverage. Otherwise, you would be facing a penalty for Part B if you had no coverage, because it happens sometimes where people say, hey, well, I don't need to go to Social Security yet because I'm not going to activate Social Security, so I don't need Medicare either. So what they end up doing is they just don't do anything, and maybe they don't even have coverage through work, or God forbid you had coverage through Covered California. If you're eligible for Medicare, number one, if you're on Covered California, you can't be on Covered California anymore. You're not eligible for the subsidy anymore, so you absolutely have to go on Medicare. And then if you're not getting employer coverage, then you start accruing a penalty if you have no other coverage. So then once you end up signing up for it, that's when the penalty hits you, and the penalty is a perpetual penalty, so it goes on for the rest of your life. So yeah, so it's always good to make sure that things are in order. Thank you.
Are there any pitfalls signing up for any one of the Medicare plans, say Medicare Advantage? Are you able to switch to a different plan, say Medicare or
So when you sign up, for example, for a Medicare Advantage plan, you can usually switch your plan every October, between October 15 and December the 7th, to another Medicare Advantage plan. But you can't, usually you cannot go from Advantage to a supplement, because usually supplemental plans you have to go through medical underwriting unless you're new to Medicare. So for example, if you're brand new, you have those two options. You either go stay on Medicare and purchase a supplement, and if you're new, you don't have to answer any medical questions. Or you can go Advantage. If you go Advantage, you get a 1-year trial period. Let's say you didn't like Advantage, you can go to a supplemental plan and they cannot ask you medical questions. But then after the year, if you try to apply, you have to answer the medical questionnaire. If you have HIV or if you have any conditions, you will get denied by the supplemental plans. The Advantage plans, on the other hand, they have to take you. It doesn't matter, if you have an illness, they don't ask medical questions, period. But that's the main difference when it comes to like Advantage and supplement. And yeah, the pitfall is that if you don't have a supplement and then you want to go to a supplement after being on Medicare for a year, then you will have to disclose your health information, and you can get denied, unfortunately.
So if you're on Medical Advantage for more than 1 year, you're stuck on Medical Advantage for the rest of your life?
And yes and no. I mean, there might be circumstances. I'll give you an example. Let's say that you are on a Medicare Advantage plan and that Medicare Advantage plan goes away. So we had a plan a number of years ago, Inter Valley Health Plan. They went away. So then that gives, like if you were on that plan, that would give you eligibility to go on a supplement without answering medical questions. We call it a guaranteed issue right. But there's always exceptions. So I mean, we know like the exceptions, but yet there's like 12 different exceptions that can happen. But yeah, I mean, it doesn't necessarily mean you're stuck there, but you are stuck there for, until something special comes up, I would say. Well,
thank you, sir.
Appreciate you guys. Thank you.
Finished.
I would say the big thing that would be important is to show up maybe a little earlier than your appointment. And I would say maybe show up 15 minutes earlier for your appointment because there could be a line at the desk. If you show up early, then you might actually end up getting roomed a little early if the patient in front of you hasn't shown up yet, but you also could wait. So I would recommend that you bring a book or a tablet or your phone or magazine, and be understanding if we appreciate you showing up early. First of all, we really do, but we also appreciate that you're understanding if we can't see you early, or if you may even have to wait a little bit past your appointment. But what we do try to be mindful of is if we are seeing you late, at least I do, is I try to still give you the amount of time you have for your allotted appointment, which is usually about 15 or 20 minutes. So I'm rambling at this point. But
Will you give us a lollipop?
I have a couple of
for
other
being
points
patient.
I want to make.
Go for it.
I actually appreciate when patients bring in a list. Try to make the list, not too much more than 2 or 3 items. We understand that there's a lot to accomplish, and you're looking forward to this appointment a lot of times. And sometimes you're waiting months for this appointment. We realize that it's hard to get in to your provider, depending on where you are, if it's Eisenhower or DAP Health or Desert Oasis, wherever. I think access is an issue, or Kaiser. So we understand that you have a lot to cover, and I actually do try to go through the whole list because I'm pretty efficient on the keyboard. But I know that most providers probably appreciate you to stick to about 2 items, 3, and then also try to avoid the and one more thing. It's really unrealistic to be able to expect to cover every single need that you have, and I would say just be willing to cover the most important issues, and then be willing to make a follow-up visit, in another month or 6 weeks to tackle some of the other things. Or you can put some of the other things like in a message, through your MyChart, or you can call the provider's office and get some of those little things met. But try not to bombard your provider too much with multiple issues, because we only have 10 or 15 minutes with you.
Bridget?
So I would say, number 1, cultivate a relationship with your staff. So your nurses, your MAs, folks like that, because a lot of the issues or things that you have that you may not be able to get to in your appointment, your nurse can take care of, right? Because we have the extra time and the relationships with the clinicians to be able to, after the appointment or at the end of the day, or if there's a cancellation, be able to sit down and say, we need this, this, and this, and get the orders to be able to take care of that. Use MyChart, right? That's what it's there for. If you have a good nurse or a good MA, they're paying attention to that throughout the day or throughout the week. So use MyChart, send messages when there's things that you think of. Instead of holding on to it for a month until your appointment comes up, put it in MyChart. We can get it taken care of and either have it done before you ever show up, or when you get there, it's in here because we review charts, right? The day of appointments, so we know what's going on. So, and remember that relationships matter. You don't have to kiss anybody's butt, but you could be nice, right? As a nurse, y'all mean sometimes. Just saying. And very few providers, nurses, MAs, pharmacists, any kind of staff, very few of us get into this work to hurt your feelings, to not take care of you, to not want to do things. So just remember that when you're getting frustrated. We're there to help. And it's okay to vent sometimes, because sometimes we just want to be heard. I get that. But remember that each relationship matters, and the better your relationship is with the entire staff, the more efficient we can run, and the better we're able to help and assist.
That's really good advice. Thank you. And, patients are scared a lot of the time. And sometimes that does manifest in less than polite interchange, and we got to be mindful of that because you are here for us. Thank you. Thank you for what you do. And Trent, if we'll revisit the question, for a 15-minute scheduled appointment in the Valley where we are short of doctors, where we are short of medical professionals, and we've got to be efficient, how can we as patients do a better job of making the most of that time with our partners?
I think just piggybacking on what Dr. Adams said is make a list. Instead of, I know there's one more thing in the grocery store. The whole reason that you went to the grocery store and then you got home and forgot it, I have to have a list, right? So write things down and track things too. If you're going to bring up a new symptom that you're having, you know that they're going to be inquisitive about it. Like, what time of day is it happening? Does it only happen when I go from sitting to standing? Kind of be conscious of the things that you want to bring up so that helps move the time along, right? Because you have a limited amount of time. I'm not texting, I'm looking at something.
Yes, he is. Kidding.
Yeah, so put a timeline with it. And then someone else said earlier too about having a list of medications. Ooh, that is a long list. Even though the nurse sometimes help with that, it's still something that your provider is going to go over and look at new medications. And then one other thing I thought is if you don't get all of your questions answered, I've had, you know what, we got to move on. We're getting bogged down in a lot of issues that we need to talk about. I'll send the patient right back to the desk and tell them to schedule the next available appointment with me. So maybe we don't need to wait that long. Use other avenues of communication with your provider, like messaging through whatever portal you use, whatever the health systems portal is, so you can kind of continue on with the care without feeling like you're bogged down. And the only time I ever get to communicate this is when I'm in the room. You can continue with your healthcare through other ways, through messaging and maybe not even speaking directly to the provider, but trying to get messages to the nurse or other people. So you don't feel like, I lost out on my time while I was there. So it's not a one-time thing. Nothing seems to ever get solved in one visit. So just know, don't get frustrated. This is something that we can talk about time and time again until we get it right.
And don't talk to Dr. Google.
Oh, we love Dr.
And Dr. YouTube. I gave myself an appendectomy.
Yeah, honestly, I think we sort of expect that now.
Yeah,
And,
yeah.
I mean, I don't get offended when someone comes in with.
Maybe they ask me even
and
more
there's
informed
AI now,
questions.
too. There's AI. I mean, people come with very sophisticated questions.
Really?
And they usually kind of know the answer already. Because they run it through ChatGPT or.
Wow.
So it's yeah, people are very. I learn a lot from my patients, honestly, just from their questions and also the information they bring in. They ask very interesting questions.
But that's a dialogue that you're having
Yeah.
with your patients,
Yeah.
and that's definitely a partnership. And you know, what are some of the time constraints that, as providers, you face? I mean, is there that generally an appointment has like an hourglass and the sand runs out?
Yeah, for me, so appointments can vary. Appointment times can vary between like 15 minutes to 30 minutes, depending on if you're a new patient.
Or if you're a lot.
Or if you have like one acute complaint, like your chest pain, or you've got flu-like symptoms, that can be like a 10 or 15-minute visit. But time constraints are, sometimes we have patients who are late, and when you have a 15-minute appointment or a 20-minute appointment, and we allow up to 15 minutes late. And so if the person walks in at minute 14, then we basically have 6 minutes left. Right. It takes 5 minutes to get room.
And then it's bumping in everybody.
And it takes me 1 to 2 minutes to actually log on for each patient. Can you imagine wasting 30 to 40 minutes every day just logging on?
And it goes back to what you said at the beginning. Come 15 minutes early.
Yeah.
And get on your phone.
And it'll be a better visit too, because your doctor or provider won't be stressed out. Looking at like, oh my God,
And not just the doctor, I mean, like you say, the support staff in the office.
Yeah.
If you're late, you're stressing them out, they're trying to get you in. Yeah, it's kind of a, I don't know, it's snowballing effect.
Yeah, and I like what Bridget said earlier too about being nice to staff. Sometimes the visit can kind of get kicked off on the wrong foot if the receptionist was rude to you or rude to you. They may not have been rude to you, but they were just thinking about something else, or maybe they were checking their Instagram. I don't know, but yeah, I would say try to overlook those things and try not to let that take you out of your visit and out of your head. Yeah.
That's going to be a lot for me. Because if there's any overthinking to do, I'm there to do it.
Real quick, we see you.
I have a question.
Sure.
Please wait for the microphone. Oh, you've got it. Please turn the microphone on.
DOHC doesn't have my chart. I have my chart for DAP, for University of California, San Diego, and now I have it for Loma Linda. But there's no way for me to really contact my doctor, who is a DOHC physician. And that would really save a lot of work and time if I could reach him before I I go to an appointment, and he could give me the answers.
Okay. Well, yeah, you're right. There is no My Chart for Desert Oasis.
And why is that?
Because My Chart is made for an electronic medical record, or EMR, called Epic.
Yeah, but DAP has it.
Yeah, well, they have it. It doesn't mean
So does
Desert Oasis has it.
Eisenhower.
They do have the patient portal though.
Yeah, but so Desert Oasis uses a system called NextGen instead of Epic, and NextGen does have a patient portal. I don't know if you're.
No one's ever told me about it.
Yeah, there's a portal, but also what you could, and I think this rule is universal within DOHC or Desert Oasis, is that you can text our phone number. You can actually just send my office number a text, and we'll answer it. But we like you to call us. We're kind of old school like that. We don't have a fancy EMR like Epic, or a portal like MyChart. Our portal is not great, but it does work. But you can actually text us.
I would say next time you're for an appointment, ask the nurse to help you get set up in the patient portal. You can check your medical records. You can send messages through the portal. Appointments are kind of sketchy to do, so I wouldn't do the appointments, but you can send messages, you can check your records, you can check test results, so it is available.
Well, I get my test results from LabCorp.
Yeah, so you can get those from LabCorp, but you can also, if you ever need to print them or if there's an issue, you can get them out of the patient portal as well. And then to the point that we were talking about before, the other thing that I want to mention is staying up on your appointments helps with time. So have you ever heard, has anybody ever said your lack of planning is not my emergency? Mm-hmm. Unfortunately, in medicine, your lack of planning can become our emergency, and so it's important that you stay ahead. And so you're getting your prostate checked, you're getting your endoscopy, you're going, and if you're sent to go, if your doctor suggests that you go and have specific labs done, you go and get those labs done. So those are the kind of things that can very quickly snowball and build up and take up valuable appointment time. Or all of a sudden, you've had this thing pending for 6 months and now you have to get in because you should have went and gotten, whatever the test is, and all of a sudden your body's going haywire because you didn't do it. So staying up on your maintenance appointments, vaccines, things like that, and I know that's a dirty word lately, but nonetheless, staying up on all those things can also help ensure that your visits go smoothly and that you're on top of what you need to do medically so that nothing does become an emergency.
Do we have a shortage of doctors here in the Coachella Valley, considering how much medical need there is amongst the graying population?
I think we definitely have a scarcity of specialists, especially in certain specialties. Primary care doctors, I think it depends on the organization.
Yeah.
I know that some people at certain organizations have a hard time finding a good primary care provider. But and at Desert Oasis, we have tons of primary care providers. So, and not everyone works for every person, right? I mean, you may not click with your provider, and you just move on, choose the next one until you find one that you do click with.
Somebody just said urologist. Yeah, how many are out there? Any urologists? We could use an extra few. Endocrinologists, can we get?
The company that DOAC referred me to is now gone. So I either go to San Diego.
Yeah.
Or I go to Loma Linda.
Yeah, well.
I'm 80 years old.
Well, good for you. You've already gone through the goalpost of male life expectancy.
Going to San
This
Diego
is gravy.
is a whole day trip.
You've done well. I know that's a long day.
So that just made me think of something in advocating for your healthcare. Since, when you go to your primary care, that I sometimes think of that as the quarterback, right? That's the person who's looking over generally all of your care, not just the specialist, but where we sometimes find a gap is, and it makes it hard to make further decisions in your care, is when we don't have the reports or findings or recommendations from specialists. And there's specialists for everything now, right? Everybody has a specialist that they're going to see. But we always, kind of in line with what you were already saying about an electronic health record or a portal where all of that information is one centralized, that makes it difficult. So when you do see specialists that aren't in that system or that aren't going to be on the same medical record or messaging system that you're on, try to get those records or bring those or write down what they say or some kind of feedback, because sometimes that I feel like is such a holdup trying to figure out, just like you said to do, I went and saw the specialist. Oh, what did they say? Oh, they say everything's okay.
One thing I like your points, Trent. One thing you can also do is ask your specialist to make sure that the notes are sent to your PCP, your primary care provider. And they usually do anyway, like I would say 75, 80% usually do, but
there could be a little lag, but yes, sometimes they don't always do that.
Don't.
So again, that's a way to advocate for yourself too, is just, hey, in case you can't find it or wasn't sent over or the fax is still waiting to be scanned into the record.
And I like what you said too, Bridget, about, carry out the orders, right? Like if you come in and you ask for 5 different referrals, the last thing we want to hear when we see you in 3 months is that you haven't done any of it. Because we wasted all that time, all that red tape, bureaucratic stuff that we have to go through to get those things approved. Other staff members that have had to, touch your chart to get things approved. We appreciate it if you do your best and try to, carry those orders out and see those specialists.
This is a question that you have not been prepared for. If, knowing your patient base, knowing this community, if you were king of the world, what kind of a best case scenario for a healthcare system should we be hoping for in this country? Because people are getting involved and they're getting out on the streets, and we're going to have a different set of people in positions of power in this country after what is going to be a landslide. What should we be as patients, citizens, neighbors want? What should we be, striving towards? It's been real good for insurance companies and pharmaceutical companies so far. What as patients and citizens should we be fighting for?
Wow, that's a big one. That's a big question.
But it's a basic one.
Yeah.
That America is going to be asking.
I mean, I would say, every system is not perfect. I think you pointed that out earlier when you said that the urology practice is no longer. Actually, that's not true. They are still, they do still exist. They just changed their name.
Right.
And they do that.
Premier or something like that.
Yeah. Anyway, so it's kind of, I think what to expect as a patient is you should expect to have good care. You should expect to be able to access specialists if you need them. The fact that your healthcare organization can't provide you with a decent specialist, that's really our fault, honestly, in my opinion. But also realize that not every specialist is perfect. We're not a system like Eisenhower who has 25 different cardiologists. you
And
know,
marble examination tables.
I mean, nothing, yeah.
It's very well funded and
They have a
endowed.
great cardiology
Yeah.
department. I mean, it's.
But I'm talking about the big
world-class.
picture for America, as it fits in with the rest of the world, that seems like it can get it done.
Well, I mean, I think for me, I mean, just broadly speaking, I think healthcare is a right. And I think that's what we should be fighting for. Is that you know, healthcare is a right, and that it shouldn't put people, you know, in the poorhouse.
And feeling in an adversarial arrangement with our providers and our insurers. And, you know, I think for a lot of people, they feel like it's like they're taking more. It's not you specifically,
Yeah.
but it's like you work harder, you get less. And the gap between the haves and have-nots.
Yeah, I think knowing who you're fighting too. You know,
Yeah.
like I think being cognizant of the fact that doctors and healthcare providers and nurses and advanced practice clinicians are struggling right now. We're dealing with a lot of people who are misinformed, and in large part we're over it. We are over people questioning vaccines and
damn right.
and coming in with wanting, you know, ivermectin for COVID, demanding ivermectin for COVID, and if they don't get it, then we get then, you know, we get insulted or
threatened.
And so just be aware of all that when kind of attacking your healthcare providers or thinking that we have more power than we actually do. Because we, you know, we're also employees of our company, so we do have a say-so in how well our healthcare organizations can provide for you, but we're not in charge in large part. So.
Well, we need to demand more as citizens.
Did you want to add to that? Because I have something too.
I'm sure you do.
Go ahead. I want to hear it, Bridget.
Just saying, remembering that no system is perfect, to your point. You know, yes, Canada has universal healthcare, free healthcare, but they also spend 8 to 12 hours in an emergency room waiting to get that care, right? So knowing that nothing is perfect, knowing that no matter where we find ourselves, we're going to have to advocate for ourselves and advocate for each other. And so as we're looking at changing or want to change the healthcare system, having clear expectations and clear lines about what can and can't be done is really, really important. And knowing that what you want as an individual may not necessarily be what's best for the community as a whole. And at the end of the day, if you don't have a healthy community, then you can't be a healthy individual. So looking out for the next person as well as yourself is critically important, I think.
I think as a first world country, if you are not taking care of the most vulnerable, you've failed.
Yeah.
You have already failed. You, and secondly, I'm firing Kennedy Jr.
Okay. All right. You're king of the
king
world for now.
So he's fired. But we have to make it healthcare more accessible to those that need it. To everybody. Everybody needs healthcare. Instead of using the emergency rooms. I have friends that still work in emergency medicine, and they are swamped with people coming in for the smallest of things because they have nowhere else to go. Even an urgent care can be expensive. For 10, 15 minutes in an urgent care, I've seen some patients sharing with me about the bills that they incur just for the most simplest of care. And that's why people don't seek it. They don't seek care. They don't get the care that they need because they can't afford it. And it's a decision between, do I get health care or do I eat? Or do I get gas in my car?
Pay the rent.
Yeah, pay the rent. So
And then that thing that they skip going to get some treatment for it gets seen by becomes much more serious.
Right.
Sick care versus
So they wind up
Sick care versus health care. That's the term.
We had a question.
Yeah,
I have a question on what do you do when your specialists have opposite opinions on things? I recently was in the hospital for a heart issue, and they did a test on me, and the specialist writes up this report that, yeah, I'll probably die soon because I have so much blockage and stuff. And they send me to a cardiologist, and he goes, oh, you have no blockage whatsoever. I looked at the same tests that he did. So then I asked my primary care doctor, and he goes, oh, I'll look into it. And end of story. It's kind of like, this doctor says this doctor says this doctor doesn't have time. Where does that leave you?
Well, if your doctor said that they're going to look into it, I would hold your doctor accountable. You know, if you expect to hear from your doctor about it, and if you don't, call them and say, hey, I'm still waiting to hear, you know, what your opinion is on these two contrasting views.
Well, he also told me he hadn't looked at an angiogram in 20 years himself, and he couldn't actually get into the system to look because he didn't have a password for it. But the two cardiologists who do this every day have exact opposite opinions on it.
I'm personally, if I were in your shoes, I would maybe get a third opinion.
It is your right. It is your right to have a second opinion. That's one of your rights, and encourage a family member to present it as, I'm not trying to be difficult, I'm just trying to be responsible and make sure that I'm making the right decision. Like, you're not going to do a remodel on your home with one quote. Yeah, right? So that's a lot of money. So your health is, money too, right?
I mean, I guess that's kind of my thing. I respect my general practice doctor a lot, and I'm not trying to be a troublemaker, but I just haven't been able to come up with an answer.
Yeah, make sure I'm doing the right thing for my health. Yeah.
Make good trouble.
Framing it.
Make good trouble.
Make good trouble.
I like the spreadsheet.
I would say sometimes even make an appointment just to discuss that issue.
I did.
That would and his reaction was, I still
oh,
don't
your
know.
cholesterol looks great. You look this. I'm like, well, I'm not here for that. I'm here for
Who's
this.
your nurse? Let me call her and let's get you straightened out.
And you know.
That brings back the idea sometimes you need that outside advocate. If you don't feel comfortable.
Your mic's not on, Ace.
Now it turned red. Does that mean the battery's on? Oh, there we go. Hello. This is what we talked about earlier, is that sometimes, if you are feeling up against things, a lot of people get shy in front of doctors also. I'm very shy though. But people are nervous to challenge their doctors, which is why bringing an outside advocate with you, because they could be your voice and they'll hear the things that, sometimes it's overwhelming. Like the situation you have, I imagine it's very overwhelming. If you have an outside advocate with you, they could be saying, not good enough. And also two more points. The other things we talked about earlier is that if a doctor or any provider is going to have an issue with you getting a second opinion, it may not be your doctor. It might not be a good fit, because that should be typical and overturned, especially with large medical issues. I just wanted to circle back to what James was saying about making sure that you get your tests done. If you had several tests that had to be called up before your next appointment. Now the reality is, unfortunately, in this community, our medical community, you can try to get it done before your 3 months is up, and you call to get your appointment, and it's 4 months away or 5 months away. So obviously, first, always has to be put on the wait list. It's amazing how many times with loneliness specifically, I get myself on a wait list for an appointment that was 4 months out, and I can come in tomorrow. So always get yourself on a wait list. The other thing is, if you absolutely cannot see the specialist, for your test or whatever, communicate with the office initially and get back on their schedule. If you know you're going to miss an appointment because of other circumstances, communicate with them right away so they can get you. That's basically showing some grace to your providers and understanding that what James is saying, that people are employees. The reality is, unless you're going to a private physician, most of the physicians in this area are associated with one of the major medical, DAV, DOHC, Eisenhower, Kaiser. So the appointment times and stuff, I know for a fact, which my provider, they are dictated exactly through the organization. This is where I think, as patients, we have to show our physicians a little bit of grace, knowing that they don't want to just give you 15 minutes. They'll talk to you all day if they could, but that's not a decision that they're making. And so when you are late to an appointment or you don't show up, whatever, you're basically screwing everybody else for that day in the office. That's all.
Thank you for saying that, Stephen.
Right behind you.
John and Jack.
Thank you. Thank you so much for being on the panel. And Dr. Adams, I really was trying to get you as my doctor. I've seen you at events before, but you're not covered under my insurance, but Desert Oasis administers my insurance. But I do take a list in for my doctor. I found that my doctor at Desert Oasis here, he doesn't check my glands ever. He uses the table that I would usually sit on as a desk, and I sit in a chair, you know. And I recently had a colonoscopy that was overdue, and I was due for an endoscopy on April 1st, and instead of which was done last April 1st after a 2-year delay. And I just feel like things are getting behind with my doctor. I had an extension for physical therapy sent in on February 26th, and he just did it on, approved it on Tuesday, so now I have to wait 2 more weeks to get reanalyzed by the head physical therapist. So now I'm like 8 weeks behind in physical therapy. And I'm just wondering, are these red flags for me, or is there, I don't dislike my doctor, I just think it could be a little more, I'm always prepared, I always have a list, I'm always early, I'm always nice to all the staff. I know Bridget, I know Trent, and I don't know if I should switch to another doctor or not, like a gay doctor or a HIV doctor. Right now, I see him as my primary. He refers me to DAP, to Dr. Kakar, who's amazing. And I'm just kind of stuck with my thoughts about my care, like checking my glands, checking my abdomen. They did a swab for to get approval for an endoscopy, but last year they didn't do the swab, and I had an endoscopy. I had an appointment for this year, but that doctor quit, so I had to ask for another referral. And it seems like it's kind of going in a circle lately for me.
Okay, I'll address a couple of your questions. So that's a little disturbing about the endoscopy. You're talking about...
he thinks the colonoscopy should take care of the things of that endoscopy.
Yeah. So were you going to Desert Oasis endoscopy, HRA, or somewhere else?
Desert Oasis referred me to Eisenhower over at Red Rock.
Okay, because we have our own endoscopy clinic.
Yes, and I told him that because I'd heard that. And so I went to do the swab, and it was like a comedy of errors. They were so nervous to see my butt, but they, you know, like they had to come and go out of the room like 12 times. And did you get the solution? I thought you got the solution. Did you get this? Did you get door shutting, door shutting? And I'm turned against the wall, you know, all exposed. And,
yeah, that's unfortunate. So back to your first question about not being able to get into me and being a Desert Oasis patient. I don't quite understand that. If you're a Desert Oasis patient, you should be able to get in to see me. But
they said you weren't on the scan list.
No, that's not true. So you can call my office. I can take care of all those things. But regarding your physical therapy referral, that may not be your doctor's fault. That could have been the referral department a lot of times, or...
I called them multiple times. I even got like a fax line to have it faxed, and the nurse told me, "Oh yeah, we approved that," and she gave me the date, and it was the date I was there for my appointment. So that was just last Tuesday. So literally
Yeah, I mean, I
5
would
weeks.
say, I would say, first of all, the system's not perfect. Mistakes happen, delays happen.
Understood.
Whether or not that's acceptable or not is debatable. But I think it sounds like you're getting decent care. You've got a provider, doctor that's trying. A lot of people won't even do it.
I'm very big into self-advocacy, so
Yeah, it's
I'm
important.
grateful for this day today.
No, it's important.
Yeah.
It's very important.
Thank you.
You guys have any comments?
Couple things come to mind, and this is generally for everybody. One is you were saying your doctor hasn't physically touched you, hasn't done like a physical kind of exam. So I will say this: one is a person can't fix what they don't know. So if you have an expectation that's not being met, talk to your clinician about it. Your relationship with your clinician should be bidirectional. You should be able to ask questions; they should be able to talk back to you. So if you're not communicating that something is not happening, then they don't know that they need to fix it. And whether that's a conversation with your clinician or with your nurse to have the conversation with your clinician or patient advocate, so talk to people. That's one. Two is, you're absolutely correct, it's necessary to self-advocate. And navigating the healthcare system. I'm working on my 10th HIV clinician. 10. I've had HIV for 14 years. Absolutely ridiculous. If I don't advocate for myself, things don't happen. I'm exhausted by that. Some of you in this room have been living with HIV twice that amount of time, right? And I know that you have to be exhausted if I'm exhausted. But we have to continue to advocate for ourselves, because each time we advocate for ourselves, we are advocating for the person that comes behind us.
Can you say, Bridget, to the doctor, you haven't touched my glands?
You can absolutely say that.
And say, please touch my
You
glands.
absolutely can say that. Definitely.
I would say, can you please examine me? I wouldn't be accusatory.
No, but
yeah. I would just say, hey, you haven't really examined me in a while. Can you maybe do an exam? I just kind of worried about my glands, and can you look at my mouth?
So when I do my senior wellness every year at Desert Oasis, it's a free thing for seniors or whatever.
Yeah.
I find that I get so much great care, like one building over, than I get from my actual primary doctor.
It sounds like you might want to keep looking.
Thank you.
Oh, that's the other thing I was going to say. I know it's not y'all. It's people outside of this room. It can't be y'all. It's y'all cousins. Some people don't want to see nurse practitioners or PAs. They only want to see a doctor.
I love them.
So keep in mind, quality of care comes from the person delivering the care, not from a title necessarily.
Yeah.
I love Dr. Adams. He's amazing. I love Trent. He's amazing. The point is, it's the person that's delivering the care sometimes, not necessarily the title. So tell y'all cousins, it's okay to see a nurse practitioner. It's okay to see a PA, right? If you can't get in to see a doctor, see someone who's going to give you care.
Yeah, that's
I
excellent.
think as a doctor, and I can honestly say this, one of my best providers personally was a PA. Yeah, it was Bruce Hinton. I don't know if you guys know Bruce, but he was my PA in LA, and he was amazing. He examined me from head to toe. He wore a tie to work, he was just like
A PA is a physician's assistant.
Yeah.
Hey, I'm happy for attention. And you know what? If there's something that a registered nurse is going to know that it's needing more attention from the doctor and pass that on. And you've seen it all, so that's really good advice.
So yeah, to Don's point, that Medicare wellness visit, anybody who's got Medicare is entitled to a wellness visit. Medicare often will email you and remind you of that towards the beginning of the year. So absolutely do that. If you've got Medicare, take advantage of that because they cover a lot of stuff. So that leaves your time with your primary care provider, and other stuff, and not the routine stuff that should happen on there. Another thing, people have questions about their meds. Utilize your friendly pharmacist. Every time you get any medication, they ask you, do you have any questions? Ask those questions. Even if they're not asking, if it's something you've been on, if they prescribe it, they are qualified and to tell you about that. So utilize that as a source because they're right there. You can walk in anytime and get that information without having to ask your doctor And then to the gentleman who was talking about the portal at Desert Oasis, I'm a Desert Oasis patient, and yeah, it's not as good as my chart, but it does work. And anytime you can utilize that portal, it really helps. If you have questions about how to use it, talk to the front desk staff, and I think they've got people there who will sit you down by the computer to show you how it works. But I know we sometimes hate to use those funky programs, but it makes a huge difference. Just wanted to share those things. Sure.
Well, I want to thank all of our providers for being available for questions. We appreciate you, and we want to be partners in our own care and take our responsibility for it and not lay it all on you. And we're happy that you are doing such a wonderful job, because we've got people that are thriving because of the great partnership they have with their healthcare providers. I want to thank the HIV Positive Aging Research Project, Palm Springs at HARP-PS.com. I thank Stephen. Thank you so very much. Ani, thank you. Thanks, Aspen Mills, all of our sponsors, and we appreciate you.
Thank you.
Oh, well, I learned a lot. I have an appointment tomorrow. Don't forget, you have a survey, and you can fill it out. And if you have your name or your email address or phone number on it, as you pass it in at the HARP desk, you will be registered to win a fabulous facial from Patrick Smith. How awesome is that? His face could use it. Thanks again.
Thank you.